grant from NIH in the Institute of Allergy and Infectious Diseases. And this is being led by Professor Andrew Grissom and Maureen Handsome in the Department of Molecular Biology and Genetics. And they are collaborating with a wide array of institutions, including Weill Cornell Medicine, to conduct this impactful work. So that's just a couple of examples of where we continue to pioneer opportunities in the life sciences. Today, we're focusing our efforts on what is truly interesting to me. This is immersive media in medicine, something I know very little about, but I'm excited that you're coming together to think about this frontier. And today's co-chairs, Joanne Defedy, professor of psychiatry at Weill Cornell Medicine and the founding director of the Virtual Reality Lab and the Program for Anxiety and Traumatic Stress Studies, Professor Andrea Wan, assistant professor in the Department of Communication and director of the Virtual Embodiment Lab, where I did get a chance to get embodied virtually one time. It was really interesting, is a great cross university partnership. So together they received a $75,000 seed grant, which is funding their collaboration in piloting personalized virtual reality experiences to address PTSD in healthcare workers as a result of the COVID-19 pandemic. The Immersive Media in Medicine Symposium is truly an exemplar, in my opinion, of the model of collaboration and disciplinary convergence, and will no doubt elevate our understanding of the life sciences holistically. By bringing together diverse expertise in a range of technologies like virtual and augmented reality, Cornell is revolutionizing medical education and healthcare by developing and providing interactive, realistic simulations. So today's symposium, I think, will be exceptional. It's an opportunity to explore the transformational potential of immersive media in medicine and how each of us may play a role in this bright future together by bridging the entire university. So just a few examples here today. I just want to thank you all for taking the time to come to Ithaca. Those who are on Ithaca already, thank you for coming to the event. And it's really a great testament to how CALS and Cornell continue to thrive in our active partnerships to drive innovative research, education, and real-world impacts across disciplines. So thanks again. Hope you have a great symposium, and I hope it inspires even greater opportunities to think boldly about our future together. Thank you.
Good afternoon, and thank you all for joining us here at the second Immersive Media Symposium. The first one was held 5 years ago in Manhattan, and I see some familiar faces from that. These programs were meant to be cross-campus to facilitate cross-campus collaborations and to be every 2 years, but we did get a bit stymied by the pandemic. However, in the meantime, as the Dean mentioned, many collaborations have formed, including Andrea's and mine and several others that we're going to hear about today. I've been tasked with giving you an overview of VR over the last 20-some years. So to me, I imagine it a little bit for anybody who has ever been to Disney and on the monorail, you know how it takes you and you get to see each ride, but you don't really stay there for very long. Well, that's what I'm gonna do. And then later for the rest of the day in the panels and other talks, we're going to go into greater depth. First, that would only happen if the slides move. No, it's not working. There you go. All right, let's try that again. So as you can see, so the middle picture is one of the first uses of virtual reality when it was very much an experiment. I'll talk a little bit about that. It was back in 2001 following the World Trade Center. all the way up to the present when we see one of our elderly citizens trying out a head-mounted display and having a lot of fun, which I'm going to talk about in a minute as well. So I'm going to run through the successes, many of which have been in psychiatry, in the area of trauma and phobias, and then also in pain. I'm going to talk a little bit about failures and challenges, and these themes are going to come up throughout the day. And then future directions, and mention a little bit about what you're going to hear for the rest of the day. I started here, and I've been using this slide for a long time. Many of our collaborators in tech and other disciplines get frustrated working with us because the thing about working in medicine is there's a basic tenet, which is no matter what we do no harm. And so we're very much outcomes focused. And so some of what I'm going to be talking about is sort of the gradual progress over the last 20 years, just been in developing randomized controlled clinical trials, which in the world of science is the gold standard before a treatment can come into use in a medical environment. But where are we now? So I said 20 years because that's when we at Cornell started using VR at the medical center. But the concepts and some of the ideas have been around for more than 35 years with research and development. And I want to emphasize research and development. There's a lot of data to support what we do now, which was not the case 20 years ago when we started out. The technology now, the picture I first showed of the actually was a reporter in the head-mounted display that we used for the World Trade Center. That was a $25,000 head-mounted display. Dell donated it to us. It was literally sunk into a grounding pole, and we needed a Dell workstation to run it. So at the time, not only was the work experimental, but the equipment was certainly not consumer grade. At this point, though, 35 years later from the beginning, we now have immersive systems for prevention, treatment, evaluation, and chronic disease management. We are moving into the mainstream. We're still not there yet, and that has a lot to do with some of the issues related to infrastructure and cost, which I'll touch on, which are rather mundane issues, but nonetheless essential to making progress. Some of the keys, so let me just step back for a minute. How do we use VR? Well, there's a plethora of treatments at this point, but there are two or three basic ones. One is immersion, to teach and practice skills. So you'll hear about the use of VR in med ed and skills training. We immerse people in a virtual world. You get to practice whatever it is you need to learn to the point where you've met a criterion and a standard to be able to go out and use those skills on a human. Some of that we do in clinical interviewing now. Another is exposure, where particularly in trauma and with phobias, it's based on the work that we've done. It's based on learning principles that are at least 100 years old, if not more, where we systematically and gradually introduce a person to whatever they're afraid of in such a way that they learn. Basically, you're resetting your brain at a preconscious level. Oh, that tall building that looks like the World Trade Center is not an indication there's going to be another terrorist attack. It's just a tall building. So we believe that we're immersing, creating the context for the memory, and giving a person to learn the opportunity to learn that that particular environment is safe and will not re-trigger their trauma. And then across all disciplines, empathy, embodying a virtual avatar who has a medical condition, where you're a medical student or a nurse trainee or whomever, and learning what it might feel like to be that person. So those are some broad uses of VR. Here we go again. Okay, we're good. Okay, so all right, successes. So again, I want to emphasize, since this is a conference at a university, what we do and what we're talking about throughout today is based on gold standard clinical research, and which studies are designed from everything from pilot feasibility studies all the way to NIH-funded and DoD-funded randomized controlled clinical trials. And at this point, there's quite a bit of evidence within psychiatry and pain for the use of VR. So for example, one of the most common phobias is fear of flying. One of my friends who's an internist told me that about 20% of her patients came in for medicine before they fly, right? So, but if you immerse someone in a virtual reality environment and go over flying with them over several weeks, there's quite a bit of data at this point in randomized trials that show that you can learn to fly again and feel safe flying. And it actually takes less time than a standard behavioral psychotherapy does. Yep. At this point, we know that there are multiple phobias that can be treated with virtual reality. It's cost effective. We can no longer go out to the airports, which used to be the way that phobias for fear of flying. One of the ways they were treated, you could go, Delta, for example, had a program where you went to the airport, you sat in the airplane, you were educated about what it was like to fly. We can't do that anymore. So having virtual environments that you can immerse yourself into, have the experience, and learn and talk through your fears with a trained therapist. These are not self-help environments. Works well, and again, as we've shown in multiple studies that it actually takes fewer sessions than behavioral exposure therapy, where, for example, with elevators, you can go into an elevator, but it's quicker to do the VR version, and it's also more flexible. So you can see those folks are saying, I'm facing my fears in alphabetical order. How about you? Okay, so now I'm going to dive a little deeper into our own work. Back after the World Trade Center, I think the CALS dean just mentioned how one of the missions of CALS is sort of practical, problem-focused solutions to real-world problems. Well, that's how we got into using virtual reality for the World Trade Center. It sounds very dramatic, but we knew that there would literally be thousands and thousands of people who developed PTSD after the World Trade Center. However, the idea of an evidence-based treatment was a new one in psychiatry and psychology, and the only treatment was, and there are only about 8 studies in assault survivors, was exposure therapy, in which you systematically and gradually expose the patient to whatever their fear is. And it requires your imagination to do that. It requires you to be able to call up your memory. There's a kind of a conundrum with PTSD in that many people don't remember their trauma, or if they do, they prefer not to. They avoid it. Avoidance is a hallmark, or they're numb. Their brain just shuts them down and they can't. Now, for those of you who are thinking, oh my goodness, why would you ever expose someone to their trauma again? The answer is, at this point I can say it works, but another answer would have been 20 years ago when we were beginning to do this work as experimentally, is that people also have intrusive images, flashbacks and nightmares. And so the images are coming into your consciousness, waking you up, causing you great distress, and you have no control over it. So one of the things that we can do by systematically and gradually introducing feared stimuli is give a person to learn the opportunity to learn that they're in a safe environment and that they can, in fact, master their anxiety. Does it work for everybody? No, but no one treatment works for everyone. And there are other therapies available now too. There are also no medications back then for PTSD. There's still nothing for PTSD that's been developed for PTSD, although clinical trials are going on now. What we have are repurposed antidepressants that are partially effective. So anyhow, this is where we were in 2001. We decided that we knew everyone wouldn't respond to exposure therapy. So we decided that we would undertake a virtual reality simulation. I worked with a very close colleague of mine, Hunter Hoffman, who's actually a pioneer in the area of pain, which I will touch upon and others will speak a lot more about. And we undertook to do a small randomized controlled clinical trial that was actually funded by NIH at the time. And I wasn't initially going to show this slide or this movie, but I decided to after all. This is 22 years old. It is the second patient in the study. He was a fire chief, he was the operations fire chief for the World Trade Center at the time. That means he's one of the people who ran the command center. He was also a naval pilot and was still in the reserves, and an engineer. He ended up in our treatment program because he had a panic attack when he went over the Brooklyn Bridge, and the ER docs advised him to get treatment. He's very public about this, so obviously he's public about it. He went on the news about it. And so what I'm telling you is pretty much a matter of public record. But anyhow, I'm going to let you speak. I'm going to let him speak for himself. And keep in mind, look at the equipment. You could never use it today. But the principles of the treatment are very much the same as they're used today. It's about 2 minutes, and I'll probably won't get through it.
Virtual reality is a proven tool for treating patients with phobias or suffering post-traumatic stress disorder. Now, it's being used to help rescue workers and victims of 9/11. Health reporter Itai Hod has this exclusive report.
Comfortable?
Yes.
Can you hear me?
Yes.
Stephen King was there the day the towers fell, and he's been dealing with it ever since.
I had a just such a total feeling that I wasn't the same person.
Like many other rescue workers, King has post-traumatic stress disorder. He's been through therapy, but it didn't work. So now he's trying this virtual therapy.
I was almost shaking. I mean, it brought it back like I was there again, watching it.
It's called virtual reality therapy, or VRT, and it uses sounds and 3D images to force patients to face their fears. Very slowly, patients are taken back to their traumatic experiences. In Stephen's case, a virtual journey back to centers. Now, as soon as the patient puts on this helmet, they're immediately immersed into a 3D environment. What that means is that if they look up or down, or even if they look sideways, the scenery shifts with them. And that's what doctors say makes it such a powerful experience. Here's how it works. First, the patient sees the towers as they were before the attacks. Then a plane appears and flies behind the towers. Experts say this readies the patient for what's about to happen. Next, a plane hits the first tower, but without sound. Then the full experience. Authentic pictures and sounds taken from video shot that day. Because it's so overwhelming, it can take up to 8 weeks for a patient to see this, start to finish.
It allows us to take it in small steps instead of.
So, as the reporter said, we don't immerse a patient fully into the environment the first time we see them. In fact, we don't even start it for a few sessions. A lot of education is provided, some grounding techniques, anxiety management techniques, and only then do we gradually and systematically expose someone over multiple sessions after they've demonstrated that they're able to tolerate their anxiety. The idea is that by the end of any one session, you should have achieved some level of anxiety reduction. The gold standard is 50%, but that doesn't always happen. Everyone's physiology is a little different. But we never, and certainly the way, this is just a reporter talking, but he gets the general idea. It wasn't proven at the time, and we never immersed someone fully in the environment right away. It's only at the patient's pace, but he was correct that it's the average now is about 9 sessions. And you can see the grounding pole in the background, by the way, that we had to have the cables tethered into in my office. So what did we do? So the feasibility study suggested that, well, what feasibility data does, people will come, they stay, they finish the treatment, often refer people to us, and we even had preliminary data that they got better. So we then got another grant. And we were thinking about, I mentioned that the treatment is based on learning principles. And so we were thinking, as were some folks down at Emory that we worked with, about treatments as learning environments as opposed to using medicines for palliative relief. And that early work was done, preclinical work was done at Emory by Mike Davis and Carrie Riesler, and they showed that mice who were given decycloserine actually did better in the sort of classical conditioning extinction paradigms, which is what trauma and phobia therapies were based on at the time. So we then added the same medication, which was actually a repurposed TB drug, and timed it so that patients were taking only during their treatment sessions. And we showed that, in fact, it did facilitate learning in this virtual environment, and our patients got better more quickly, to put it in common everyday language. This paper was published in Neuropsychopharmacology about, 10 years ago now. Fast forward, we then got a multi-center Department of Defense grant in which we assessed 250 people across a VA, Department of Defense active duty site, and Cornell was the civilian site, which we gave this medication in a randomized controlled trial. We also got genetic markers and other biomarkers, which I'm not going to go into here today. It's a little off point, but very interesting. data, and this was published 2 years ago in Translational Psychiatry. One of our major findings was that people do better in VR if they have a comorbid depression, and about half of people who have trauma also have a depression. And so that was an important finding and a tiny, tiny step toward the development of a differential therapeutics for the treatment of trauma. And just quickly, just want to emphasize, since we're here at Cornell, this is a Cornell-funded conference, that the development of treatment for trauma is very much a Cornell story. We started with 9/11, and you can see the old equipment. Then we went on to multi-center collaborations for treating our veterans returning from Iraq and Afghanistan. In fact, the way we got into that at Cornell is a lot of blue line disability. So New York Police Department are also usually in the reserves or serve in the military. And same with the fire department. Our colleagues at the fire department gave us a call and asked if we would see some of their reservists coming back from the war for PTSD. And so that's how we got into developing virtual reality simulations and working with our combatants. And as you can see, as we go along, the equipment improves to the point now where it really is consumer grade, kind of the way your TV is. If any of you have trouble, there are a lot of tech people in the room, but if you have trouble programming your universal remote, well, that's an issue with virtual reality equipment as well. So today, as the dean mentioned, Dr. Wan and I are collaborating on developing virtual reality simulations for healthcare workers. It started out with environments specifically related to the pandemic, and we're broadening it more generally to all healthcare workers, given the high rates of PTSD and depression and other psychological distress in healthcare workers, which actually predated the pandemic and is now just that much more intensified by what's happened with the pandemic and since then. Okay. Fun fact, people prefer VR. Why? But it doesn't actually affect the outcome, at least so far. That's what we've shown in our research. Why is it important? Well, one of the things we do know in mental health is if you want the treatment you're given, you're more likely to come. And the greatest threat to the integrity of any treatment in psychiatry and psychology and human behavior is people just not showing up. I mean, the modal number of treatment sessions is 0. So this is an important finding, more broadly speaking. The work we did then led to the idea of combining medicines and technology and treatment. The term was coined by, among others, Kerry McCann, who started Care Therapeutics, and his company, which I was on the scientific advisory board of at the time, made it all the way public, but then failed shortly after going public. And I'm going to talk about that in a minute, not his company per se, but the issues in general. In general, at this point within psychology and psychiatry, there are a range of environments and conditions, diagnoses, and just states of being like anger that we can use virtual environments to treat, and it's all backed by evidence. Just quickly into pain, I want to touch on it around the same time we were starting work in trauma. Work was beginning with pain, which my collaborator Andrea Stevenson will talk a lot about. She's doing some very exciting stuff in social VR now, but back in the beginning, it was just one patient, one treatment. And that there's a body of research that suggests that pain can be reduced by almost half in some cases in using virtual environments. The work started out with burn patients, which some of you will know the standard of care is morphine for wound debridement, but even morphine doesn't hold a person's pain. So one of the pioneers and one of our colleagues, Hunter Hoffman, started developing immersive virtual environments using the same headset that we use for the World Trade Center. In fact, that's where that headset was first used for burn patients. And he found that patients combining standard of care treatment like morphine with VR, patients got greater pain relief. In fact, not only that, not only do they get greater pain relief, but if you look at the last bar, they actually said it was fun. So and that to me was just astonishing. Right? When I went to our burn center, there was also a lot of trauma, and we gave someone a headset to use during a procedure. He looked at me and he said, I thought it might help me a little bit, but I never thought I'd tell you that I had fun in the hospital today. That's something to think about. It's almost, it's not, we can certainly measure it, but it's almost an intangible benefit that I think deserves more thought. Okay, again, lots of academic research that others will go into today. Okay, so fast forward, where are we today? Just what are you going to hear about the rest of the day and tomorrow? At this point, with consumer grade technology, lots of research suggesting the efficacy of immersive environments in different populations, from patient populations to training to patient education. We see the use of VR in clinical skill training, in surgical skill training, in perioperative preparation, use of complicated equipment and tools, team training, and as I said earlier, to facilitate empathy. So one situation where VR, a good use case would be for low frequency but high stakes situations like a pediatric emergency. Another, as I said, is perioperative planning. I happened to hear a really interesting presentation by a neurosurgeon who talked about how once he started using VR with his group, instead of sitting down over a cup of coffee and mapping it out with a pen and paper, he believed they had improved outcomes because you could pinpoint more exactly the route into the tumor. Again, lots of other diagnostic uses in psychiatry, physical therapy, medical imaging, and other areas. Okay, future and ongoing. I'm just going to touch briefly on these and then leave some time for questions. Failures and ongoing challenges. Well, so the question is, I thought I was going to ditch this slide because it's old, right? It initially said 2014 to 2017, but then I read the list when I was going over and preparing for this, and I went, wait a second. Pretty much, except for the cost, every problem that existed 10 years ago still exists today. With some of the key ones being that the technology is consumer grade and inexpensive, but it's not quite turnkey. So for those of you who've used VR, this is a challenge to all the tech folks in the room. It has to be to the point where you can hand the headset to a nurse who's going to use it in your patient with pain and not have it interrupt his or her workflow, and not have an automatic update, and not have it be compatible with the IT infrastructure, which I know some of our collaborators in med ed, like Doug Cohen, will talk about later on today. Those problems are the same today. They're better, but they're still there, and that creates situations where people get really excited and then they go, oh, wait a second. I don't have the training for this, and we don't have the extra staff. So that's one of them. Another one is healthcare reimbursement. We're just to the point now where within the mental health space, some folks have done the very tedious job of getting CPT codes, which are the billing codes, to specifically use immersive technology in order to get reimbursed for it. If we can't get reimbursed for it, we can't use it in a clinical setting. Up until now, I've just been talking about research, but we will have some colleagues today from psychiatry talking a little bit about using Adora Canalopoulos, for example, will be talking a little bit about using VR in a clinical setting on the inpatient units during COVID. And guess what? The company that they were using blew up, and now they don't have the technology. Training of clinicians, what is the standard? How do we do it? And then, of course, there's the old issue in medicine where it takes 17 years for an idea to go from the bench to the bedside. And so it's a very slow process. The good news is we're there. It's 20 years, and we are using it, and it is being rolled out. But we still have some of the same problems today that we had at least 10 to 15 years ago. So again, I hit all of that. Again, this is great. There's an explosion of hardware. It's inexpensive, but there's no universal platform. So in my lab, if you were to take a tour of it, we have like 7 or 8 different kinds of headsets. Why? Because we have to use a different headset depending upon what we're using it for and what software we're using, which is again an issue in rolling out immersive technology in medicine and other even educational settings that, again, we'll hear more about from others today. Here we have a good news. Good news is there are now 457 companies where there are only 157 5 years ago when we did this conference. The bad news is they blow up. This would have been my financial disclosure slide 5 years ago. Paratherapeutics went public, didn't make it. VR is the one that did God's work in trying to get CPT codes for insurance. They also recently failed, and the other company, just as an example, didn't even make it to their first series of funding. So there are a lot of issues, and on the business side, I don't know if there are any business people here, but we could certainly use your help in developing viable models. I'm asked that all the time, like, what is a viable model for using VR in clinical practice? And that's a tough one. Finally, interdisciplinary collaborations. We're all here today under the same literal roof. We come from tech, we come from Weill Cornell Medicine, we come from CALS and other academic centers up here in Ithaca, and we kind of talk different languages. And so getting a team to work together to appreciate the other's expertise and how to use it. And so it's like learning a second language. What I like to say is my first language may be healthcare, but my second language acquired on the job is technology. And so I challenge all of you in technology who want to work with us in healthcare to solve problems to come spend more time with us and go on the floors and see what happens when a nurse can't use the headset and has to put it aside. And to think about outcomes. Again, in medicine, without outcome data, it's very unlikely to be adopted as a standard of care. But okay, the future that you're going to hear from other people about, avatar personalization, effective computing, the integration of biosensory data into personalized avatars. With effective computing, we'll actually be able, we can at this point, although again, it's not turnkey, interpret and process and possibly simulate some cases of a human emotional state. I'm going to show you now another video.
Hi,
before I
I'm
end.
Ellie.
by
Thanks for
calling
coming in
it
today.
characteristics.
I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential. Are you okay with this?
Yes,
So, how are you doing today?
I'm doing well.
That's good. Where are you from originally?
I'm from Los Angeles.
Oh, I'm from LA myself. When was the last time you felt really happy?
When was the last time? I don't know. Yeah, I'm not someone who's really like, I don't have any real highs. I feel like I'm a level person. It's just happy. I guess to answer your question, probably a couple months ago.
I noticed you were hesitant on that one. Would you say you are generally a happy person?
I'm generally happy.
Start at the top
It's
of
just
your-
lately there.
When was the last time you...
That work was done out at USC and is ongoing. My collaborator, Skip Rizzo, and his team at the Institute for Creative Technologies. This is actually fairly old, so it's an early example of using eye tracking and body movement to then control the avatar to ask certain questions. And also, ultimately, the idea is that the program will change to different scenarios, that the avatar will ask different questions based on the data, whether it's blood flow in your face, your voice as a biomarker, and other ways of eye tracking, body movement, to then adjust the virtual world. Just going to end real quickly with personalization, which is my project with Andrea at Stevenson One here, funded by the Cross Campus Initiative. Here you can see generic looking healthcare workers. All of the environments to date have been generic. It's the soldier, usually a male soldier. We have there, with maybe slight changes in race, but you can't see yourself. With the improvements in technology, now we can create an avatar that looks just like you, with your consent. And so some of the questions that we're asking now are, since we know that the first and third person perspective are cognitively and neurobiologically distinct, will it affect treatment outcome? Will it engage people more? Can we use it to treat a primary depression? Can we use it for moral injury, where you can actually see what you did during the pandemic and perhaps have the insight to go, oh yeah, that was really difficult. It wouldn't have been possible to save that patient's life, because guilt is, many healthcare workers carry a tremendous burden of guilt for what they couldn't do during the pandemic. This is a quick example. That doesn't look exactly like me, but you get the idea. You can create an avatar that looks a little bit like you. And just a big thank you. There are over 25 years, there have been hundreds of people probably involved in these multi-center studies. So thanks to you all. And I'm going to turn it over to my colleague, Andrea Stevenson-Wan, now for her. Okay. Oh yes, I'm a New Yorker. I speak fast and then move on. Sorry. Any questions? I guess not. So, right.
Thank you all so much for coming here. And also thank you for letting me hustle you out of the hotel so you could get your lunch. I hope that everybody is satiated now. I'm going to talk about the clinical uses of social virtual reality. So my name is Andrea Stevenson-Wong. I'm an associate professor in the Department of Education. I direct the Virtual Embodiment Lab. I'm going to say a few things about that in the context of what Dr. DeFede said, because I think it's relevant when we think about collaboration. I'm not a clinician, and I would not step into this space without having collaborators who did have that clinical expertise. I think that that's a theme that will come up again and again throughout this symposium, how important it is to have that joint expertise. I'll say one other thing that will be relevant when I talk about some of the work we do in our lab, which is that we focus on consumer virtual reality hardware, which is different from, I know, what some other folks do, because we are interested in the translational aspect. So our process is generally to work with our populations of convenience, often the wonderful students and people around Cornell, and then take what we believe we've learned and see if we can bring it to a clinical setting with our collaborators. So I wanted to add to that when we think about how we collaborate and what we hope to bring from this symposium, which is more collaborations like the ones that we'll be highlighting throughout the day. Okay, so I'm going to give a quick overview that may be very old news to some of you, but I'm going to try and put this information in the context of current projects. And in a few spaces, I just couldn't bring myself to talk about any projects other than the ones that I know will be presented later today, so that I might just call out the names of people who are doing cool work in this space. So I'm going to talk about social virtual reality, avatars, and agents. So as we know, both of the technologies that allow us to be embodied in avatars or to interact with agents have been making enormous strides. So I'll talk about that a little bit. I also want to bring up old and new social virtual worlds. We have social virtual worlds that are immersive now, but there's actually a long history of health research in 3D screen-based virtual worlds. And I'm going to talk a little bit about some interesting applications that are sort of entering a new space when we think about adding a social component. And then I'll end with some risks and next steps. The reason why I wanted to talk about social virtual reality at this symposium is because a lot of the classic work that we're used to thinking about is in a solo environment. And so it's exciting to think what the ability to bring other people or other entities into that space will allow us to do. So social virtual reality, as I'm going to discuss it, I'm going to say that it allows a person to interact with other users or with embodied agents in a virtual environment that can be a social experience. To do this, you would be embodied in an avatar. Here's an example of a Ready Player Me avatar. I want you to note sort of the characteristics of this avatar, because one of the things I'm going to talk about in the end, which is a sort of an ongoing process, is to improve the avatar resemblance to people instead of looking like an adorable cartoon. So if we think about how we can experience immersive media, we have a breakdown, and this is taken from a paper led by Stephanie Bellina that's coming out. We can think of experiencing it alone physically, and you're also alone in the virtual environment. So this could be a single player game. This could be a lot of the pain therapies would be, you're there might be snowmen throwing snowballs at you, but there's not really any social interaction. And that in itself, as we heard, for conditions like people who are being treated for burn pain was already like a leap forward in immersion. We can also think about being together physically and alone virtually. And you might see this if you were to give people in a hospital different games to play so that they could just distract each other, but they wouldn't be playing together. Where it gets interesting is when we think about being together virtually with another person. And this could happen if you're by yourself and you're connecting with someone remote, for example, a friend and family member at home, or if you're connecting remotely with a therapist. You could also be together physically and together virtually with another person. And there's some interesting examples of having people jointly play a game together in virtual reality or augmented reality, where you're jointly looking at virtual content, but you're also in the same space, and you can kind of riff off of that physical presence. And I want to add a fourth category, which is you can be alone physically, but you can be together with an agent. And while work with agents has existed for years, we're seeing now, both with the example from USC that Dr. DeFiti showed, and also with some upcoming examples that are being used for education and for emotional comfort, some really interesting examples of being together with an agent. I think this is probably not news to most of the people in the room, but it's worth reviewing. Avatars are controlled by other humans. The ability to transmit nonverbal behavior in particular can lead to this higher sense of social presence and togetherness in immersive virtual spaces. And it also allows you, being embodied in an avatar allows you to be active to the extent that you can be, which gives you the ability to do more amusing things like playing games. It allows you to learn things like practicing tasks together if you're in a learning context, even if you're separated physically. And also, the fact that your behavior is recorded at a high level of detail means that you can track that information to provide information about people's states of mind, and then manipulate that therapeutically. So that can both be an enormous resource if we think about using that information therapeutically. And as I'll talk at the end, it does raise concerns about data privacy as well. So that's not a trivial amount of information to track. Agents powered by new AI tools can exhibit nonverbal behavior, which they could do before, but now it can interact with the behavior of the avatar that's controlled by another person. They can speak using natural language with participants. And the vision for these agents is that they can replace human companions when they're unavailable or when they're undesirable. And so one of the other things I'll talk about at the end of the presentation is how careful we have to think about this idea of replacing human companionship. But we can think of cases where, for reasons of privacy, for reasons of timing, that there are cases where you could want to interact with an agent over a human. For example, if you're practicing over and over again with a virtual patient, which I think some people will be talking about later, it's better to do that with an agent than to exhaust a human person. I also want to point out that social interactions through avatars have existed long before consumer VR. Those of you who have been in the field for a while will remember sites like Second Life that offered sites for patient education, increasing awareness about health issues. They had sites for support, training sites, marketing sites, and research was also conducted in Second Life. Second Life is still around too. It's still in use, although it is a its focus has remained on being a non-immersive virtual world. And this funny picture is an avatar demonstrating getting a mammogram, which is sort of an educational, was on a health site designed to educate people about health options. But now that we have the ability to advance the slide, do we have that ability? Okay, got it. Thank you. But now we have newer consumer social virtual worlds that allow us to be in a headset with other people. And what that provides us is the ability to have these embodied interactions with friends and strangers all over the world. And there is starting to be interest in how this may be therapeutic. So far, I don't think in VR chat, I don't think the CDC has a presence there, but there is already research on people using these social VR systems to sort of self-treat for social anxiety and to support their social connectedness and well-being. So this is an area of research that is sort of interestingly calls back research in social virtual reality. I'm going to say a little more about that, what that means for researchers. So it used to be that if you wanted to have a social virtual reality experience, you had to set up a networked environment. It was pretty challenging to do, generally lab-based. So it was a rare experience to have an immersive social VR experience. That's changed. It is possible to use a consumer social virtual world in the context of a study. There are some risks and some benefits. There is an existing user base. So if you're thinking about an experiment, there's a large user base in VR chat, and it is also possible to recruit in other less popular platforms like Meta Horizons. It is important to remember that these are places. They don't exist physically, but they have a very real digital existence, and they each have their unique sort of norms and cultures per world. So it's not the same as walking out onto Ho Plaza. It is a different environment. Although they are public spaces, it is possible and in fact increasingly common to create private spaces in these worlds. So if you chose to create a private space, if that was appropriate for your study, that would be a way to have a little bit of protection so you weren't just out in the chaotic, so the sometimes chaotic public spaces. But the conclusion is if you want to use an existing social virtual world, you want to think about the cultural ramifications of that. There are other enterprise platforms that also have social world components. I'm thinking there's a number of examples, and I think we'll hear about more during the course of the symposium. EngageXR is one, Spatial is another one. And it's possible to have a little more control over your experience in there. You can have a private version of those platforms, and because you're paying for it, you can get a little more support than if you just stick your soapbox out in VR chat. And another thing that you will hear about during the course of the symposium, I know many of you do this, is custom built applications. Sometimes these are built in game engines like Unity or Unreal. We do know that they require more programming expertise. So this brings us back to the benefits of collaboration, although all, I would argue, of these platforms require collaboration with people who kind of know the lay of the land. And that gives you even greater control over data and user experience. And that is, as we'll talk about, important. This slide's a little bit redundant to what we saw, but I did want to mention that new advances in embodied agents do open new opportunities to simulate social interactions. This is a screenshot from a project of a researcher I'm working with Yejun Yu, who built a little agent avatar, allows people to practice de-escalation techniques. So it's not strictly a medical application, although you could see that that's would come up in a clinical setting. And just it provides the ability to tune the nonverbal behavior to what the human participant is doing and saying, respond in natural language, and even specify responses. Like you can see probably from the behavior of this character that she was pretty hostile. So we had a little hostile agent for the participant to interact with. So now I'm going to slow down a little bit and talk about multiple examples of social virtual reality adding to existing uses of immersive media or creating totally new opportunities. And the ones that were top of mind, because I knew we would have more great presentations on these later today, were pain, physical rehabilitation, psychiatry very broadly defined, and thinking about education and training. So I pulled some fun examples, and I'm going to start with what brought me into the field, which is my interest in how immersive media could be used to address pain. So you can see on the left of the screen, this is a screenshot from Snow World. Dr. DeFede mentioned this was Hunter Hoffman's project that he brought to burn patients now more than 20 years ago. Amazing. This was really what made me interested in the field. So we know that virtual reality is helpful for people undergoing acute pain. So a logical step, once we have the ability to connect people with others socially in virtual reality, is to ask, could this enhance the pain mitigating qualities of virtual reality? So previously it was super difficult to do. Now it's much easier. So the image on the right is a image of a paper that's currently under review, where we put two people together with strangers in a virtual environment. So I'll talk a little about that project and its precursor project now. So this picture in black and white shows a image of what a participant in our first study looking at social interaction and how it affected pain threshold in virtual reality. It shows what they saw when they looked at a conversational partner. This was a study that we ran in 2019 and had a pretty simple comparison. We had people alone in a virtual reality environment, and we had them conversing with a stranger in the virtual environment. In both cases, they were talking about geography, so not the most riveting topic, but we did find that with these induced pain tasks, with our population of convenience, we were able to increase the amount of time that people would keep their hand on a thermo that was slowly heating up when people were in the social condition. But not just a tiny bit, right? This is an induced pain task, so it was like half a degree, but it was a pretty consistent finding. So we were interested in pursuing that. And after our paper came out, actually another research group did a similar project looking at experimentally induced pain where people were interacting with an agent, and they were told that the agent was either a person or not a person, so an agent or an avatar. They didn't have a behavioral task. They had people rate their pain and took some physiological measures, and they saw a effect on physiological measures, but not on a pain report. And I think that both of these studies highlight this idea that when we're thinking about how to bring virtual reality to patients, we often have to deal with this unsatisfying reality that it's not that externally valid. It's like the people aren't really in pain. They're not really upset. So it's like we're moving the needle just a little bit. But my argument that I would make to you all is that when we're thinking of the enormous resources, both of staff and of money to bring headsets in the hospital, we're all building on each other's work. So there's a good rationale for doing these kind of baby studies with college students who aren't actually suffering at all. So we got this little bit of movement in looking at how social experiences could address pain. And we are now bringing that into a hospital setting with our collaborators, Dr. DeFidi, Dr. Reed, Dr. Zaja, and Dr. Robert Winchell who runs a trauma center down in New York City to see if we can look at the feasibility of bringing a social virtual reality study to patients in pain in a hospital setting. So now I'm going to talk about some work that's not, that's a little further away from the work that we're directly doing in the lab, but that are some cool examples of something that we think of being an ability of virtual reality. So many of you may be familiar with mirror therapy, which was actually Ramachandran, who's a person who invented mirror therapy for phantom limb pain, said at the time, he's like, I would have used virtual reality, but it was too clunky because this was back in 1996. So he was right. So he had the setup where he would put a mirror in front of participants and they would be able to move one hand and see their phantom limb. So classic experiment on visual feedback on movement. Obviously now we can readily do that in virtual reality, and there's a number of groups, including my own, who have put out mirror visual feedback modules in virtual reality. But now we can think about how we can go beyond those solo experiences to either work with clinicians in a telemedicine context or to set up collaborative or competitive gameplay with other patients, friends, and family members. So this is an example I pulled from an older study where people were able to participate with in a multiplayer mode to do a rehabilitation with virtual reality. So you can see that the patient can move their hand and their hand movements are being tracked, but they have company across the table to participate with them. And this increases people's performance. It's more motivating. And as we heard earlier, it's more fun, which is a precious commodity in hospital and rehabilitation experiences. So that's something else that I want to reiterate is we do want to think about the outcome measures, but people's enthusiasm to try virtual reality is really encouraging. So I'm going to touch a little bit. I know that we have a panel on this, so I wanted to mention psychiatry and therapy. So telemedicine, we learned a little bit about this idea that we can have a remote connection with the therapist or the clinician. I'm going to say a little more about the project that Dr. DeFidi and I have been working on. So we have a recreation of an emergency room that is designed to be used for patients with PTSD. It can be customized so they can see themselves, perhaps other people that they know in that environment. If we can have these self-resembling avatars, again, raising questions about data security, but also really exciting opportunities. But if we think about this in a telemedicine context, which has become increasingly popular post-COVID, we think about other cool things we can do socially. We can create a remote connection with a therapist or another clinician and the patient. We can allow the clinician to toggle to be connected to the participant in a headset who's at home, didn't feel like coming into the city. They're wearing a headset and they're navigating through the virtual environment, but we wouldn't want to just say, well, now you do PTSD therapy at home. We don't want to just turn people loose. That would be dangerous. So the clinician is present, but they're remote. They can be present in the virtual space, potentially could join the patient in VR, or they can communicate by audio and toggle between what the participant is viewing through the headset and what the participant is doing from the third person perspective. So it adds this dimension we've seen in the video of PTSD treatment previously. It's like the therapist is right there, right? They're guiding the interaction, but now they can have these other tools to allow them to look at other, at what the patient is doing and seeing from additional perspectives besides seeing on the screen. And this opens a lot of other interesting potential to be addressed cautiously. The patient and clinician, we can replay what people do in a virtual space, allow the patient and clinician to observe and reflect on patient reactions. So it's very exciting. The citation on the bottom is not our project, but it's an example of the effectiveness of remote cognitive behavioral therapy using an in-home virtual reality toolkit. And this is something that I think there's going to be increasing interest in as this becomes more feasible. Okay, I want to be mindful of our next speaker, so I'm going to speed up a little bit. I wanted to shout out to Noah Robinson, who had done some interesting work on virtual support groups. We can think of this as sort of a therapeutic version of VR chat. So it's a sheltered, anonymous, safe virtual space for interviewees to engage, in this case, in group therapy for substance use disorders. So this is a feasibility study, but it's the comments that participant made are highlight these potential advantages of it being accessible, anonymous, and offering companionship. People could be honest and feel present with other people, but be truly unidentifiable, and be able to form social connections with anyone from any place. So you're not limited to the people that are in your little town. You might be a barrier to sharing information depending on where you are, but to sort of expand that ability to get social support from real people. And I think the last thing I'll talk about is the ability to engage with hospitalized patients. So I did mention that we're taking our social virtual reality experience into the hospital and seeing if that's something that would be useful for older adult trauma patients who are in the hospital for an extended stay. There have been existing studies looking at using this for example, for children who have a very extended stay in the hospital to reconnect them to school and their family, using these sort of immersive technologies to bring them back in the classroom with a camera to give them a platform that they can engage with their friends when they are forced to remain remote. And this one, I pulled this set of images from Dr. Benjamin Locke's website at the University of Florida, but I know there is even, can I say even cooler? Very, very cool, even cooler virtual patients that we're going to hear about a little bit later today. So I'm very excited to hear about that from our colleagues. And I also know that we're going to hear some very cool things about some work being done on patient education. So I'm just going to put these pictures here and think about what agents can do, and then I'll leave the time for us to learn about that in the upcoming education panel. So just to close, there are some concerns that we need to think about. So we heard about these barriers to use in the healthcare system. There are some other concerns that I'm thinking about more from the perspective of a social scientist who's interested in thinking about what the technology can do. We want to think about representation. If we're saying that this is for anybody who might be in a hospital, we need to be sure that we can represent anybody who's in a hospital and not just anybody who looks like the current crop of avatars. And we need to think about accessibility and cost issues. And the speaker following me will talk about some aspects of accessibility in fantastic detail. I've mentioned patient privacy and security, but that will continue to be a topic when I say how incredible it is that we can pull all of this information from the way you move. You should be worried about how incredible it is that somebody can pull that information about how you move. And the last thing I want to say, and I get to say this because I'm the discussant for the group on agents, is we are on this balance of thinking about preserving human connection, right? So we always say, why do anything in VR? We want to have people be better in their relationship with themselves and their relationship with other humans and their relationship with the world around them. So we think about these amazing tools to get people feeling better and out in the world so they can connect with other humans. So avatar representation is constantly improving and still imperfect. Um, Accessibility issues. Headsets are still heavy, often require two hands to use them. Doesn't have to be like that, but it often is. They largely rely on audio and visual stimuli, very inaccessible to people who are deaf or hard of hearing or blind and low vision users. Much cheaper, but it's still not cheap. So we have to ask ourselves, when are we justified in using this? And it does require infrastructure and internet connectivity. So I am going to close there and I realized I only thanked half the people I meant to because I duplicated my column. So if you don't see your name up there, it's because you were in the column that I duplicated. But I'm so excited to take time for our next speaker to get loaded up. And so I'm going to step away so the Zoom team can make sure that, that she can connect, and I will yell to answer any questions.
There's also a microphone for questions as well, if anything.
Yes, sir.
So sure.
The use of agents seems like such a fascinating next step. And I'm also thinking about some of the unfortunate, like, kind of horror stories of people being driven in a fragile state by an unsupervised agent to do ridiculous things or things like self-harm, right? And from a medical context, what kind of guardrails can we envision? We're probably not at the state I'm imagining where we could ask and generative AI to, like, on the fly create new immersive spaces for a person in real time, but it's not that far away probably, right? So yeah, that's the.
Okay, so I feel like there was three questions wrapped up in there. One of them is like, who can say how we should use agents? Well, probably everybody here. Like there's a lot of people here who are qualified to address that question. And then the second question is, what do we think about the ability for people to build virtual worlds through text or through speech, which is actually something that's being tried and implemented, like not just for video, but also for 3D models. And I think that's such a fascinating question. I don't have the answer. People have been saying for a long time, like, what if people use VR and it drives them out of their mind, right? And it's not a trivial concern, but it's also not totally new in terms of any media. So I think that we should continue this conversation on the panel that's upcoming in just a couple hours. And are we Zoom connected? I see a cool presentation. Okay, I'm going to just make a couple announcements. If I dragged you away from registration and made you sit down and eat lunch, you may sort of trickle back and get name tags, but it's not urgent. We're not going to kick people out if they don't have name tags. If you are a speaker and have not checked in, we will ask you to sign a release form. If you're a speaker and you are supposed to meet up with me and Dr. DeFede after the reception, then come find us after the reception and we'll cart you off to our slide 1. Advanced immersive media accessibility disabled. And now I think we are ready for our next speaker, Dr. Sherry Azencote.
Okay, hi everyone. Can you all hear me and see my slides?
Command. Yes.
Okay. So I have some videos to show. So I'm sharing sound, but as a result, you're going to hear some of the text to speech that I use. So feel free to just ignore it or listen to it or whatever you'd like to do. I am going to try and turn on my video here so you can also see me for a second. Zoom share toolbar window. Start video button. Zoom share tool. Start video button. Stop video button. Okay, hello. So while I'm giving the presentation, I'll turn it off just so that I don't have to be self-conscious about looking at the screen in a weird way, and then I'll turn it on for Q&A. So let's go ahead and get started. I'm going to speak to you today about advances in accessibility in immersive media, also known as augmented and virtual reality. So we all know that augmented and virtual reality devices are becoming much more mainstream. Consumer devices are becoming a lot more affordable and available, and people are actually using these devices mostly for play, but also for many other applications, some of which you'll hear about in the symposium. And for me, I became excited about augmented and virtual reality technologies back when I was finishing my PhD at the University of Washington. And at the time, if you all remember, Google Glass had just come out. So Google Glass was a sort of augmented reality device of smart glasses. And there was a lot of hype around them, quite a bit of consternation as well. But for me, I was excited because I saw the potential for these devices to be used as a tool for people with visual impairments. So I myself have a visual impairment. And when I finished my PhD and started my faculty position here at Cornell, that's what I devoted my research to, figuring out how we can use augmented and virtual reality devices to support people with disabilities, and specifically people with visual impairments. So for example, I looked at different problems that people with visual impairments experienced when they were out and about in the world. And we did some studies. One of the problems that we identified that didn't have any current solutions to, or even current tools to help alleviate this problem, was something as simple as finding a product in a grocery store shelf. So this is when you're at a grocery store or at a drugstore and you've already found the correct aisle. And now you need to find the exact kind of Tylenol, extra strength, headache, or whatever it is that you're looking for. And so for a sighted person, you can scan the shelf and the product pops out at you. This is called a visual search task. It's a very basic visual perception task. But for a person with a visual impairment, this is incredibly difficult. So what we saw in our study was that people had to pick up one product at a time, look at it very carefully, maybe use a magnifying glass to see exactly what it was, and then move on to the next product. And this was the most frustrating part of their experience shopping. So we designed an augmented reality prototype that would address this problem. So this is quite a number of years ago, so the technology was much clunkier than it is today. But essentially what we did is we used computer vision to automatically detect a certain product, a target, and then we designed visual cues that were visible to someone with limited vision that would help them identify the product. So it would make the visual search task doable, in other words. It would make the product pop out because of these visual cues that were pointing at it. So examples of the visual cues, you can see them on the screen. There, we put a frame around the target product and we flashed it. So we alternated the frame color from white to black, from white to black. Another visual cue was that we extended red lines from around the periphery of the display and converging at the target product. So even people that weren't looking in the direction of the product or had a limited field of view, they were able to follow the lines and find the product. And we did a study to compare finding a product with this prototype compared to people's existing tool. And we found that even our clunky prototype completely outperformed people's current best efforts of finding a target product. So this was really exciting. And this is an example of just one particular project, but the concept here can be applied broadly. So this visual search task is something that we do all the time, not just for a certain product on a grocery store shelf, but can be used to find the exit sign or a door when you're looking to get out of a building or a room. It can be used to find the bathroom sign, can be used to find a friend in a crowd. Even when we're walking, we're constantly doing a visual search task to look for obstacles. But all of this happens at a subliminal level that we're not necessarily conscious of. So there's a lot of potential for these devices to support people with visual impairments and more broadly people with disabilities in ways that are just not possible today with other tools. But what I realized when we were working on all this projects was that I had to have my students do all of the programming. This is a startup screen from the MetaQuest 2. And for someone with a visual impairment like myself, it kind of looks something like this. It's completely not usable. So growing up, coming along in my career, I was always a builder. And especially in grad school, the earlier parts of my career, I was always building the prototypes myself and hacking the technology. But I was completely unable to do this. And it was a paradox because I was unable to program these prototypes that at the same time I felt had so much potential to help people with visual impairments like myself. And I'm not the only one who has some trouble using virtual or augmented reality devices. According to the CDC, 1 in 4 adults in the United States has some kind of disability. So whether you have a visual impairment or a motor impairment that prevents you from using buttons like everyone else, or a hearing impairment that prevents you from hearing sounds like everyone else, many people have some sort of limitation that will affect the way that they can use or experience these new technologies. So I realized this was a huge problem, and at the same time, something extremely rare happened. And this thing that happened was that I actually had some money laying around that was not allocated, and we didn't know what to do with it. This money was allocated for doing some kind of workshop. So I proposed to my colleagues to put on a workshop on XR accessibility. And the goal here was really to focus on how we can make the devices themselves accessible rather than just looking at how we can use the devices to support people with disabilities. So actually making the devices themselves, the software, the applications, even the developer tools fully accessible. So we put together this workshop in the summer of 2019 in collaboration with Yahoo, and it was a big hit. We had people come from academia, a bunch of researchers from industry, and a lot of disability advocates. And immediately after this workshop, we decided to launch a research initiative, which we called XR Access, to promote the agenda that we set forth in the symposium. The goal of XR Access was to push forward research and development of augmented and virtual reality, of accessible augmented and virtual reality technology so that they can be usable by everyone, including people with and without disabilities. And the XR Access initiative is still going strong. So we do a lot of research, advocacy, and education. And as part of, we also have an annual symposium. We've already put out the call for the one in the summer, this summer. It'll be in late June, and I can provide more details about that later. And I wanted to now give some examples about a specific research project that we did under this scope of XR Access, of making XR fully accessible. This project is called VR Guide, and it focuses on making social virtual reality accessible to blind and low vision people, so people with visual impairments. So again, this is just one project I'm going to focus in on to give you all a taste of the kind of research that's currently being done at the forefront of XR accessibility through XR Access. We weren't the first ones to look at how to make virtual reality accessible to blind and low vision people. So in the past, the approach that researchers have taken has been to just add a bunch of sonifications to objects in the virtual space. So for example, you can hear the sound of water here. If there is a water fountain in the scene, it will emit the sound of trickling water. And if a character, an avatar, is walking towards the water fountain, then you'll hear the sound of footsteps. So all of the objects are sonified and all of the actions are sonified. And this has been the prevailing approach. The problem, of course, is that now as VR has evolved, and especially with social VR, where multiple people join a single virtual environment, things have become a lot more complicated and unpredictable. So it's going to be completely overwhelming to try and sonify all the objects in the space, as well as all of the avatar's movements and actions. And at the same time, we want people to be able to socialize. So if you're trying to listen to everything that's going on in order to understand it, you're really not going to be able to communicate with other people. So we need a different approach. We need something that will scale to these much more complex environments. We took inspiration from the real world, which is much more complex than those simple VR scenes like the one that I showed you earlier. And in the real world, people with visual impairments often handle complex and unfamiliar environments with a technique that's called sighted guide. This is actually pretty simple. This is when a blind person will hold on to the elbow of a sighted person. So you kind of walk behind them and to the side, half a step behind them and to the side. And then by simply touching their elbow, and it's important to touch the back of the elbow and not to take their hand, you can feel with pretty high fidelity what their body is doing. So you can tell if they're walking up the steps, they're turning around corners, walking through doorways, negotiating obstacles, and so on and so forth. And that way the blind person can simply follow along, and this gives you help in navigation. But of course, the other nice thing that you get from a sighted guide is the simple fact that you're walking with another human, so you can talk to them. You can ask them, what's going on here? What are all these sounds? Can you tell me there's a coffee shop around me? I hear some people laughing over there. What's so funny? And so on. So there's actually a lot more to sighted guide technique than just navigation, but it's primarily used for navigation. So we sought inspiration from sighted guide. And the nice thing about a social VR environment is that we can have multiple people in the space. So we thought, hey, why not have a sighted guide join a blind or visually impaired person in a virtual space so that they can provide some navigation assistance. We developed two research questions. So the first one was, what are blind and low vision people's needs when using a sighted guide in virtual reality? So we wanted to see exactly what needs can we identify when a sighted guide was present, and what are some design approaches for a sighted guide in a virtual environment based on those needs and people's preference. So in other words, how should we design a good sighted guide experience? And to answer these questions, we put together a pretty basic sighted guide prototype. So our general approach here was to put together a basic prototype to give people an experience that they could later reflect on and we could get insights from to address our questions about what are people's needs and what are possible design approaches to address those needs. So we built 3 environments that emulated municipal parks, something that everyone was familiar with and had enough objects and possibly other avatars, something to give people some material to navigate through. And we allowed multiple people to enter these virtual parks. And when a guide, an avatar designated as a guide, entered the space, a participant or a blind user was able to virtually grab on to the guide's elbow, at which point the blind user would move along with the guide based on the guide's movement. So this was the way in which the guide was providing navigation support. So once the blind user had grabbed on and was holding, quote unquote, virtually holding the guide, then wherever the guide moved, the blind user was automatically taken as well. And then the user could let go anytime they wanted. And this was the basic idea. Using this prototype, we conducted a study. We recruited 16 blind and low vision participants. And let me show you an example of the kind of interaction that we saw with participants and the guide. So the guide was one of our researchers on the team, Jasmine, who's at the symposium. So here we go. Here's an example.
All right, can we just continue on a path? Like, is there a path that goes all the way around it?
Yeah, it looks like there's a path right behind us that goes to another area of the park.
Okay, let's turn around and do that. I'm gonna grab on again.
All right, so you can see that the participant is asking the guide about the environment. Is there a path that goes around the park? She's trying to understand the layout of the park. And then she says, okay, once she understands with the guide's confirmation, she says, okay, then let's go around. Let me grab on. So she's referring to this shared movement, the navigation assistance there. And after this clip, she virtually grabs the guide so the guide can take her to wherever she wants to go. The students did a very extensive analysis of all the interactions between the 16 participants and the guide. And they found that the most common type of interactions were requests for information. So the participants were asking the guide about visual elements of the environment. Can you tell me what's in front of me right now? Can you tell me what the layout of the park is? Is there a path leading to the gazebo? Things like that. The second most common type of interaction was a request that was confirming information that the participant already thought they knew. So something like, we're in front of the gazebo, right? If we keep going on this path, then we'll hit the water, right? So that was very common, just participants needing that reinforcement. And then the third most common type of interaction, or you could say the least common type of interaction, was actually requests for the guide to do things. So for example, to navigate. So in real life sighted guide technique, the sighted guide is viewed primarily as a navigation aid, but in the virtual space, that was the third most common type of form of assistance, but still used. We noticed that the participants fell into two groups in the way that they conceived of the guide. So one group viewed the guide as a tool, and their interactions with the guide were very to the point, pretty formal. They called the guide. And in contrast, the rest of the participants seemed to really appreciate the guide as a companion. So their interactions were much friendlier. They asked the guide for her name. And one participant even wanted to dance with the guide.
Oh, I want to dance. Eight, 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 eight.
So you can see here by the bobbing camera, this is from the guide's perspective, that the guide has obliged and is indeed dancing with the participant. There was a lot of discussion and thought given to the guide's appearance. We designed the guide's avatar to look more or less like she could be a researcher on our team. So she was kind of a conglomeration of the different researchers on the team. She was a young woman wearing, modern clothing. And we asked participants at the end what they wanted the guide to look like. Could look like anything. It could even be invisible. And they had all kinds of ideas and preferences for this. Some participants appreciated the guide's appearance, but they wanted her to be dressed appropriately to the type of environment. So, for example, if they were going to a work function, they'd want her to be dressed formally, versus a casual function, they wanted her to be dressed less formally. Some participants, especially the ones who thought of the guide as a tool, didn't want the guide to have an appearance at all. They just wanted an invisible assistant that others wouldn't see. And interestingly, 4 of the participants independently said that they would like the guide to be a bird perched on their shoulder. So this was the idea that the guide could be an accessory rather than a separate entity, but just something that still has its own embodiment, but lives on the participant. There are many interesting future directions that we can take this. And in fact, since I originally prepared this presentation, we have been doing a lot of work on this project. You can think of how to make this guide experience a reality in different social virtual reality platforms. So how would you, there's a lot of questions about how you could train guides and who these guides would be and how could you make them available to people on demand. So different guide frameworks that we could experiment with. And of course, you can also look into developing an AI guide that didn't require a human at all. And that's actually a project that we are currently working on. The guide is just one example of a project to support people with visual impairments. But like I said, 1 in 4 people have a disability in the United States, 1 in 4 adults. So it's extremely important to think about the diversity of human experiences. And the fun thing about VR for a researcher like myself is that there are just so many open problems around the usability of VR for different groups of people. So, for example, we have projects looking into what challenges people with ADHD and autistic people face when using social VR. And there has been a bit of work also done in other universities on how to make VR accessible for people with hearing impairments, people who are deaf. And there are also people with motor impairments who may need different or alternative ways of input. So lots of open problems and very important area of research. I'd like to thank everyone who's been working on this research, especially Jasmine Collins and Crescentia Jung, who were the lead researchers on this project. This is also a collaboration with Andrea and her lab. And with that, I'd like to take any questions. Good, and there's time for questions. So I'm happy to take any questions about XR Access, about the VR Guide project, or about XR accessibility in general. I will say one more thing, a plug for XR Access. If you are interested in this kind of material and this kind of research, then sign up for the XR Access mailing list, and you can do that on our website, xraccess.org, because we do have a lot of different types of activities and ways to get involved. So I promise we don't spam you. We just send a newsletter that has pretty relevant material in it that you'd be interested in. So questions?
Real quick, can you hear us on this end, on your end?
Yeah, I can hear. It's a little low though.
Zoom share toolbar window. Start video button. Option. Command. Command.
Thank you so much for this really incredible presentation. I was wondering if you know of anyone or if anyone has any thoughts about creating a tool that would let a developer see what their environment would look like to someone or experience how it would be experienced for someone with different kinds of disabilities. I'm thinking about like kind of beer goggles, but is it
yeah. I don't know of anything in particular for VR. I know there have been research projects. I don't know if there's a commercial tool off the top of my head, but I wouldn't be surprised if there is one. I'll just say that these simulations are very tricky, and I was very hesitant to put one into my presentation because they're not accurate at all. And, you know, if you've been living with a disability for an extended period of time, your experience is not like someone who just puts on, you know, a set of glasses that blur your vision. But they give some idea in the right direction. So, you know, pros and cons.
Stop video button.
I'm
Zoom share
going
toolbar
to
window.
respond to James's question to say that I know that XR Access has as a resource for looking for tools to make your environments more accessible. If you're interested in that, and I will say that I've been to XR Access and really enjoyed it. It's an amazing group of people. So I think your question was like, how could I be better? Like, how could I do better as a developer? And XR Access is kind of a portal for thinking about how to do better.
Yeah, yeah. And you might want to email info@xraccess.org with that question, because I'm pretty sure Dylan, who answers those emails, would know if there's something commercially available.
Questions?
Hi, Sherry. Awesome presentation. Thank you so much. Quick question about the first project you had presented. I believe it was Q Vision or something.
QC. Mhm.
Yes. QC. Do you recall what gaze estimation model you were using? Were you using a gaze estimation model in that?
No, we weren't, but I would love to hear more about that if you think that we should have. That's not something I'm familiar with.
Well, I would love to connect with you later.
The technology back then was pretty rudimentary, so our prototype was, you know, it wasn't very advanced. It was really a proof of concept.
Might have time for one more question. Anybody has one? Okay, well, thank you so much, Sherry, for that great presentation.
Okay, thank you.
Chat button. Participants button. Stop video button. Chat button. Mute my audio button. Mute my audio button. Share button. Remote control. Show meeting. Show participants and content button. Slide 32. Questions. Stop share button.
Good afternoon, everybody. So it's nice to be in the audience in beautifully cold Ithaca. So what I want to do is a pretty broad topic, new technologies throughout the lifespan. And I'm a clinician researcher at New York Hospital, but today I'm going to be talking mostly about being a clinician and giving you the perspective of the new technologies and what applications they have in healthcare. So my journey at New York Hospital started about 25 years ago. And here I am, bright-eyed, bushy-tailed geriatrician getting ready to go to work. And that hairdo, in fact, does look a lot like Bob Dylan. People said I stole it from him, but no, he stole it from me. Well, if we fast forward 25 years, the astute observer of the audience would say, well, there's a little less hair, but this guy is still pretty passionate about delivering clinical care. So I want to start my talk with three axioms. The first is we have out of control healthcare spending in this country. The second is our healthcare system does a great job of delivering acute care, but a terrible job of delivering chronic illness care. And the third axiom is there's a causal relationship between the two. Poor chronic illness care leads to out of control healthcare spending. So what's the role of digital technology? So I know this is about immersive media, but I'm going to be speaking more broadly about all technologies, some of which some of you study, and what's their role in improving chronic illness care and reducing healthcare costs. These are 2022 data. We know this, that we spend on average about twice as much as other developed countries. in terms of healthcare spending. If we want to look at it a different way, the proportion of spending relative to our GDP, we continue to be an outlier, and this trend is sadly continuing. So what is a chronic disease? Well, it's something that lasts for a long period, typically years. It requires people to have frequent contact with medical providers. And in almost all cases, it negatively impacts their quality of life. And I've listed a non-exhaustive list of the kinds of chronic conditions that I get presented with on a regular basis, from hypertension to anxiety to heart disease to cancer to dementia to chronic pain. So why is it that we do such a poor job of delivering chronic illness care? We don't train providers in a way to do it. We aren't paying attention to lifestyle factors which might prevent some of the chronic illness that we have to manage. We're not attending to social and behavioral dimensions of chronic illness. And one of the worst things is we continue to deliver pretty fragmented, poorly coordinated care, which makes it hard for people with multiple chronic conditions to get care. And perhaps most importantly, the payers continue to reimburse acute care over chronic illness care, which is a big driver of cost. What's its impact at a population health level? 60% of all Americans have at least one chronic condition. 40, and these are adults 18 and above, 40% have two or more. There's clearly an association with age. Older adults are disproportionately affected, with 80% living with two or more chronic conditions. It causes a significant strain on healthcare systems. 70% of hospital stays, about 83% of prescription costs. More than 70% of all healthcare spending is attributable to chronic illness care. And clearly, most of Medicare spending is due to that. So what can we do? Well, we should change the way that we train our workforce, healthcare workforce. We should begin to attend to lifestyle and social and psychosocial and behavioral dimensions of chronic illness. We should be developing new models of care to minimize delivery of fragmented, poorly coordinated care. And a fourth thing that I'm going to talk a little bit about today is, what about improving individual self-management skills? And what are those core skills? I won't go through all of these, but they range from things like patient education to better symptom monitoring, effective patient-provider communication, and skills training, as well as socialization. And it's certainly true that our system does a poor job of helping patients acquire self-management training. So many of you are actively working in one or more of these technologies. We've seen in the healthcare system and in other industries really an explosion of new technologies over the past 15 years. And this is a non-exhaustive list here. So this slide is really here just to say, what's the role of these new technologies in beginning to address and assist people in acquiring more effective self-management elements that range from patient education to communication to physical activity maintenance. And again, the question is, can new technologies improve chronic illness care? So when you think about it, you've got 8 technologies at a minimum and 7 core self-management elements. There are about 700 unique ways to put those together. And a simple example would be a voice assistant that might help older adults better adhere with their medications. We could also imagine a program where we have an application with some wearables and some text messaging where the goal is to promote physical activity and socialization. So I want to turn now to a common chronic illness, and that's chronic pain. Typically, we define it as something that lasts longer than the normal period of healing, which is 3 to 6 months. And I've listed some of the common causes here, things like spine disorders, osteoarthritis, cancer, diabetes, very common cause of pain. As many as 40% of people who undergo surgery have persistent post-surgical pain. And cancer treatments are also a common cause of persistent pain. Here's some prevalence data across the lifespan, incredibly common problem. It's estimated that about 50 million adults report pain on most days or every day, and these are 2019 data. And we know that experiencing pain on a regular basis is associated with lots of adverse health outcomes. And here's a list of just some of those outcomes, from deconditioning to falls to social isolation to depression to decreased physical functioning. So we know that accounts for about 40% of all symptom-related outpatient visits. That's about 100 million outpatient visits annually. Back and joint pain contribute to about 350 million lost work days each year. And the estimated annual cost, both in terms of healthcare costs and lost productivity, is about 550 billion. So big driver of healthcare costs. So can these new technologies enhance the care that we deliver to people with pain? And here is a slide demonstrating interest by searching PubMed. And we can see that in 2010, there were about 2,600 articles published that focused on pain or had mHealth or eHealth or digital health in the abstract or title. And this number increased to about 26,000 in 2024. I spent a lot of time on clinicaltrials.org. All funded clinical trials have to report data and their measures and the study outlines. And you can see based on the data here that pain is certainly well represented in terms of the number of completed studies, those that are active in recruiting that use some kind of digital technology as part of the clinical trial. The Roybal Center is a center that brings together translational researchers from Ithaca as well as the medical campus, and we've been in existence for 32 years, funded by the National Institute on Aging. And we've been supporting work on pain and technology for the past 10, from looking descriptively at how older adults may have social support interactions using multimedia interactions to supporting people to develop an app that has AI components to track physical activity and make recommendations to enhance physical activity, to developing a mobile health application with health coaching features, on and on. And a lot of this work done by folks from the Department of Communications here, as well as establishing a research agenda on this topic. I want to turn now to what the evidence base says about the value of these tools for improving pain care. And there have been at least 4 systematic reviews published recently. And what they show is small to moderate treatment effects in salient outcomes such as pain, function, quality of life, but significant heterogeneity in the ways the digital tools are employed. Interestingly and not surprisingly, there are no long-term studies. So these are short-term clinical trials that last weeks, maybe out to 12 weeks, but we don't know the benefits of these tools in longer-term settings. Few of the studies report adherence outcomes. So how are people using the tools over time? Of the subset that do report adherence, we see drop-off or decrements with tool use in the weeks as the studies continue. Very few focus on the cost of delivering care using the tools. But interestingly, no differences were found in treatment outcomes in the subset of studies that compared face-to-face versus digital care. So that's an important finding. What they're saying is, you know, we're seeing equivalent outcomes whether the care gets delivered in the clinic or delivered digitally. So what I want to do now is give you some findings from what I think are 5 very salient studies published in the past couple of years. The first is a study that wanted to evaluate the efficacy of a web-based training program to enhance physical activity and to reduce pain that used text nudges 3 per week, where the goal was to teach people exercise programs and enhance adherence. In this study, there were 206 adults. All of them had knee osteoarthritis, and it was a randomized controlled trial. The control arm had access to the website with information about arthritis self-management, but that was basically it. So they had good adherence. Almost 90% of people completed the program, and there were clinically significant differences in favor of treatment that were observed for the primary outcomes of pain and physical function. They concluded that self-directed, free-to-access web program constitutes an effective method of improving patient outcomes. There's a second study that looked at the efficacy of a 12-week smartphone application that had an education element along with exercise training components. And they administered this to about almost 7,000 people. This was a Swedish study. People to get into the study had to have either hip or knee osteoarthritis. And this was a cohort study, so it's not a randomized controlled trial. People in the control arm got usual care that was delivered face-to-face. So what they found, 80% adherence in both arms, so very good adherence to what was being asked of participants. Both arms achieved clinically meaningful reductions in pain, which was the primary outcome, out to 12 weeks. The cost of delivering the digital program was a quarter of what it cost to deliver the face-to-face care. So they concluded, the authors concluded that a digitally delivered program was non-inferior to customary face-to-face care. This is work done by John Piet in his lab at the University of Michigan. This was a study published 2 years ago in JAMA Internal Medicine. What they sought to do was take a 10-week cognitive behavioral program that was self-directed and delivered via the internet and administer it to determine its efficacy in individuals who were adults with chronic back pain. This was a randomized, controlled, non-inferiority trial, and they had about 300 people in the study. There was an AI component in the intervention arm where daily surveys were administered to track symptoms, and the AI collated the data, and then made recommendations to intervention arm participants that could include either a little bit of recorded therapist feedback, depending upon symptom burden, or if there were a little bit more symptom burden, 15 minutes of a telephone session with a therapist, or 45-minute phone session with the therapist. And people who were randomized to the control arm got routine CBT delivered by phone, and it was 10 sessions. Both groups evidenced significant reductions in pain intensity and pain-related disability. There were no between-group differences out to 6 months in this study. So the digitally delivered CBT with an AI component appears as effective as standard phone-delivered CBT. And importantly, the therapist contact time was reduced by 70% in this study. Study 4, this was a study to assess the feasibility and preliminary efficacy of VR-delivered strength training intervention for adults with knee OA. Small pilot study, so only 30 people in the study. What was asked of them? They asked them to undergo an exercise program 5 days a week for 30 minutes out to 12 weeks. And they got in this immersive experience, a guided exercise regimen with outdoor garden scenes. As a positive reinforcement, virtual flowers would blossom when participants completed the exercises, and the VR was combined with an app that recorded their exercise times. And the control arm got a paper version of the exercise program, but that was it. So acceptable response rates and retention rates, the adherence was quite good in the intervention arm. And there was a trend. Remember, there were only 30 people in the study, so they couldn't achieve significance, but a trend towards positive treatment effects in the area of pain and stiffness in the intervention arm. And so they were able to demonstrate the feasibility and preliminary efficacy of this VR intervention for those who have knee osteoarthritis. The last study I want to share with you was done by a doctoral student here a few years ago under the direction of Jerry Gay. Jamie Guillory was her name. And what she wanted to do was look at the feasibility and preliminary efficacy of delivering a very light touch, supportive, a positive affect enhancing SMS text messaging intervention that was delivered obviously by phone. She recruited about 70 people for the study, all of whom had chronic pain, and employed a randomized controlled trial. And all participants downloaded an app where they had to report symptom burden on a daily basis over the 4-week study period. And control arm people got usual care as part of the study. So in terms of results, there certainly was a positive effect in reduced perceptions of pain and pain interference, as well as increased positive affect at the 4-week outcome assessment. There was good adherence with the daily assessments that were done as part of the study, and the authors concluded that text messaging could be and is obviously a feasible and promising approach to deliver pain care. So what's the summary in terms of the evidence to date with respect to these new technologies and their role in enhancing pain care? I think it's fair to say there's a growing body of evidence that these tools can improve salient outcomes in older adults, but all of them have been conducted over the short term, and we're talking about a chronic illness, so understanding the value of the tools over longer periods of time is critically important. As important, preliminary evidence suggests that the cost of care may be substantially reduced, and that's critically important. Few of the studies report harm associated with these new technologies, and I'll come back to that. So I want to close with some key challenges, and I think these challenges are pertinent whether you're working in immersive media or you're working with a chatbot or you're working with passive sensing or wearables. And the first is this disconnect between the pace of technological development and the time that we need to establish benefit, which is quite slow. Joanne talked earlier about clinical trials being the gold standard for determining evidence and what most healthcare practitioners want to see in terms of, does this intervention in effect have a benefit? And it often will take a year or more to get the funding to do the study. It may take 2, 3, 4 years to enroll sufficient numbers of people. Then you analyze the data and you have an answer. 5 years has gone by and the technology you sought to determine its value is now obsolete. And so it really raises the question whether the kinds of standards that we put in place to quantify benefit are appropriate when the pace of development is so fast. The second challenge many of you face and we face in the work we've done is this problem of data tsunami, generating too much data. And this is a problem not only at a patient level, but the provider level and the health system level. So the patient level is, there's too much data. What do I do with the data? At the provider level, they're already burdened with too much data and you're asking them to absorb more. So what's critically important is these data are analyzed and synthesized into small bites so that they're in fact, we're communicating something that can be quickly actionable at a healthcare system. Otherwise, we're going to overwhelm people with data, and I don't think that there's going to be room for adoption. I'm going to preface this by saying this is an anecdotal appraisal, but in talking with people, colleagues in Dallas and Seattle and San Francisco and San Diego and Miami, what I hear is there's very little uptake of the tools in clinical practices. And it raises the question, is the problem just an industry that's slowly adopting the tools? Or are we developing tools that aren't appropriate for that setting? And there's not an answer to the question, but I think it's one that we should be thinking about and why it's important to have stakeholder engagement on the front end as we develop tools that can enhance the possibility of adoption later on. So putting my clinical hat back on, this next challenge is really comes from what I gain from sitting down with patients on a regular basis. And that is that a key element of health is not having to pay attention to symptoms or the symptom burden or the demands that come from having a disease. And so many of the applications that we ask patients to employ on a regular basis do exactly that. And all I can say is I think that's a disincentive for regular use. And so what that says is maybe our data collection might need to be more passive in its nature, but active collection of data where we're forcing people to reflect on the burden of disease, I think is going to be problematic, particularly when used over the long term. Coming back to this point of, and this is not only true for developers of new technology, it's true for all of us who think we have something that may benefit people over time. And that is, our focus is on the benefit, not on the possible harms. But we've got to be mindful that there may be harms associated with the tools that we're developing and testing. Some of you may have seen this article in the Post published this week. An AI companion suggested he kill his parents. Now his mom is suing. So this was published earlier this week in the Post. So the point is, again, we need to be thinking about the possibility that harm may be associated with some of the tools we develop, and we should be looking for those in the development testing phase. Ultimately, obviously, the benefits need to be weighed against harms. So the last challenge I want to share with you before ending is, clearly payers are keen to figuring out ways to reduce healthcare costs, and they're looking at these data that suggest, well, if we can get the same kinds of outcomes at a fraction of the cost and the fraction of the time that a healthcare can generate these kinds of results, why shouldn't we be adopting these tools on a regular basis? And so I do think there's going to be a huge pressure in the near future to shift away from customary care delivery models. So I could easily imagine very soon not having a history taken by our physician, but a chatbot with an AI component that takes that history, collates it, looks at your past history, looks at the past history of hundreds of thousands of people who come in with similar complaints, and generates a differential and a workup plan. And so what's the role of the human being? And so I do think as we get into this new frontier of technology and its role in healthcare, we're going to be rethinking what role do humans play? Is it going to be in communicating empathy, although we're finding that empathy is obviously well communicated with the tools many of you are developing? Is it in sitting at the bedside and helping people at end of life? It's a little unclear to me, but I think it's an open and active question we should be contemplating. So I want to thank you for your interest. I know we have a break coming up. We've left a little time for questions, but again, thanks so much for your interest in this information. Any questions?
If you had to summarize one key piece of advice for emerging technologists who are pursuing a PhD or graduate studies and are interested in going into supporting folks who are clinicians or practitioners in some way, what's the one piece of advice you would give to us?
Yeah, it is to have as much contact and interaction with patients and healthcare providers as possible to get their perspective about what's feasible. I think that's, Joanne mentioned it earlier, the idea of bringing stakeholder groups together is so critically important to hear their perspectives and understand, well, this isn't a go, and what are the real needs? What are the pressing needs? So the more input you get from real world patients and providers, I think the better off you'll be. Yep.
Hi. So you mentioned earlier that one of the key challenges was to not having patient pay attention to the symptom or actively track those symptoms. I was wondering, what type of symptom usually do you ask patient to report? And then if you have any insights on how to, I don't know, make it less of a burden,
Yeah. So, well, I think it's more really the frequency of assessment. So, classically, and all of you, maybe some of you have been fortunate not to be patients, but think about your own patient encounters. You go in and the provider asks you how you've been doing, and you may have a cough, you may not be sleeping well, you may have a pain in your ankle. And then the next question comes, well, temporally, let's look at that, whatever it is, whether it's a cough, it's a sleep problem, it's the ankle pain, and you are being forced to retrospectively now go back over time and begin to provide some details about how frequently that may be happening. So imagine using a tool that could ping persons to assess symptoms on a regular basis prior to a visit, so that you've got more objective data. That offers all sorts of opportunities, but again, particularly from a diagnostic standpoint. But the point I wanted to make earlier was the frequency of assessment. So if we're asking people to provide symptom assessment data on a daily basis, that can be burdensome. And I can't give you an answer of, 2 times a week, 1 time a week. I think it's going to be quite individual to a person, but certainly 7 days a week, day in, day out assessments are going to be burdensome for most people. Good questions.
Hi, I was wondering for technology important ACPT codes for this kind of tool statement.
Yeah, Joanne mentioned that earlier. I mean, I think we're starting to see some, but it's lagging. And are there some for VR applications, CPT codes? So the question is around CPT codes for certain technologies. Did I get that right?
Well, it seems that both payers and others are very eager to replace clinicians, our most valuable asset. And in this technology that you raised a lot of questions, valid questions about the role of AI, in your perspective in this immersive technologies, what do you see the one thing that can really augment the clinician's capabilities, provided that there are guardrails, right?
Yeah.
To help.
Yeah. So it probably is going to be AI synthesized. So the question, if people heard, what would I consider as clinician to be potentially the most useful of all of the tools? And I would say it's going to be AI programming to analyze large groups of data to help me make better decisions for individual patients. That's and I think that's coming.
Since you mentioned AI technology, I'm curious from like a clinician standpoint. Sometimes AI can, have hallucinations and everything. How much are you willing to trust AI, and how much do you think that other clinicians are willing to accept AI as the new implementation?
Yeah. So, as a clinician, I think each clinician would say they're going to look at what AI generates and reflect on its relevance and whether it's concordant with their own judgment, their own clinical judgment. And I'm guessing that these kinds of studies are being done, perhaps have been done, and I haven't seen them. So if it confirms clinical judgment, a set of symptoms, and I'm thinking, well, that most likely means X, and AI does the same thing, that just adds some security to my own clinical judgment and thinking of that the path that I'm on to help this patient is a good one. The problem is going to be when there's a disconnect, when the AI suggests something that I don't think about. But it may be that the AI, obviously the AI may be better, and we probably will see that. And we certainly know there's evidence of that in the ability to detect early cancer in mammogram readings because of AI's role in Finland and other countries now. So, but I do think, as a clinician, you're going to compare it with your own clinical judgment. These are great questions, by the way. Thank you for these. Well, then I think it must be break time. Thanks again.
So we have break now. If you have a demo that you need help setting up with, could I get the demo people to stand up? So Peter is waving his hand over there. So demo aid that I don't see right now. Kevin, are you helping with demos? Okay, Kevin's here helping with demos. And in general, when you see people wearing red Cornell swag, you also put that back on. Those are volunteers who can help get you organized, get you your name tags if you need them. So don't hesitate to ask. And I think our food is there and coffee's there.
Intelligence as ways to improve lives.
Hi, I'm Sarah Saja. I'm professor in the Division of Geriatrics and Palliative Medicine at Weill Cornell Medicine. I also direct the Center on Aging and Behavioral Research. And with my colleagues, as just explained, we do a lot of work in terms of VR applications and other types of technologies to support older adults. And we'll talk a little bit more about that in a minute.
So Carrie Reed, geriatrician, professor of medicine at the Medical College. I direct Cornell's Roybal Center, which supports research. A lot of that research is on looking at the role of technology as a means of mitigating pain in older adults.
So our field of laryngology, although it is very focused on one part of the human body, it's very broad. So we treat singers, performers who are struggling with their vocal performance. We also have patients who have breathing difficulties. We have patients who have swallowing problems and some patients who have chronic cough. So all of these different patient populations present different challenges that are often chronic and need to be managed in a multidisciplinary way. We work with speech and language pathologists. So just to give you some ideas, for instance, in the voice space, one of the issues that people might encounter is stage fright. So there have been some efforts around using VR to help alleviate some of the stage fright, and there's it's been ongoing research. We're not the first one to do that. It's being explored also for giving presentations, and that's an area that is being explored right now with vocal performers. In the area of airways, some of our colleagues have been exploring patient education to really explain the different complex anatomy of airway stenosis, which means that you have a narrowing of your airway, and it's difficult to understand for patients because it's very complex anatomy. It can involve different levels of the airway. And so it's actually pretty easy to reconstruct the airway in 3D using CAT scans and to present that to patients with a VR headset for them to really understand what their pathology is and how to intervene. In the area of swallowing, right now we have an interest in exploring VR for patients who have anxiety around swallowing. We've seen a lot of that after COVID. There's a particular diagnosis, which is called ARFID, which is avoidant restrictive food intake disorder, that we're seeing more and more in our clinic. And it's usually in younger patients who just are afraid of choking and will really restrict what they're swallowing and lose a lot of weight. And right now, there are not many specialists who can offer management for that. So if anyone here is interested, we have a lot of patients in New York City who would really benefit from this technology. So that would be a great area of interface. And then finally for cough, we're now exploring the use of VR technology as a distraction mechanism so that people don't focus too much on their throat irritation that can lead to cough. And so with this project, we're trying to collaborate with a company that has a product. It's a French company. So it's an interesting collaboration with industry. And then finally, one particular project we've explored and we're currently using VR for in our clinic is VR for management of acute pain for office procedures. We do a lot of office procedures are very painful. It's more acute pain. It's actually really helpful for us to have the VR headset because it doesn't cover the nose and we need access to the nose and the mouth. And so we have to have special environment that don't require head movement because we need the head to be still. And we also want patients to, they don't need to manipulate anything, but we want them to focus on breathing calmly. So there are a lot of, relaxation techniques that can help, breathing techniques, and we've partnered with one particular company that provides a product in this space. So let me know if you're interested. We always love to collaborate.
So yeah, we have a number of VR projects going on. Dr. Zaja and I will split our discussions of these projects, but we're both principal investigators of the GREAT Center, the Center for Research and Education on Aging and Technology Enhancement. And really the whole point of the center is to ensure that older adults can reap the benefits of existing and emerging technologies such as virtual reality. A lot of times technology is designed by 20-year-olds for 20-year-olds without considering the needs, preferences, abilities of older people. So our center is existing to help develop guidelines for how to design for older adults, how to design technology specifically, and also really examining what is the potential of emerging technologies for supporting cognitive engagement, social engagement, health management activities for older people, both with and without impairment. So one of the big projects that's underway right now is the CAST VR project. CAST stands for Cognitive Activity Social Technology System. And what this system is doing, it's a virtual reality system that's going to be home-based to provide social and cognitive engagement for older adults within their own home. And we know that social isolation is a big problem. We know from the Surgeon General's report last year that social isolation is devastating for mental health or physical health, increased morbidity and mortality risk. So what we're trying to do through virtual reality is provide older adults within their home engagement activities that are fun, that are leisure-oriented, that allow them to engage in some degree of physical exercise and cognitive exercise and social connectivity. So that is the process, but you just can't develop the technology and put it in people's homes. What we try to do is a user-centered iterative design process that has older adults involved in the design at every stage, from needs assessment. So what's this technology need to do? To usability. So is the technology usable by adults with various abilities? And also then we do large scale efficacy trials to make sure that it is improving people's lives, that's having, it's both useful to and usable by older people. So we're looking at in the large trial, which will have about 200 people, if people have the system in their home for about 3 or 4 months, does this change well-being? Does it change quality of life? Does it change social support? And right now we are in the process of, we did some evaluations of usability. We just completed a relatively large preference study. So we exposed older people to lots of different types of VR applications and asked them to rate. Is this something you want to do? Do you think you'd find this fun? Is this something engaging? And we're going to use that information then to start building the CAST system. After we build the CAST system, we'll do multiple rounds of usability testing, including usability testing of tip cards and instructional support for how to use the system, because these are somewhat complex technologies, especially for older people who may not have experience with virtual reality as much as younger people. And then after we do all that, it's a multi-year process. We're doing a relatively large usability study within people, or efficacy trial within people's homes. So that's the nature of the project. And I'll talk a little bit more about the challenges when we get to those questions. I'll then turn it over to my colleague, Dr. Sasha.
Hi. So Wally and I are doing, Dr. Boot and I are doing another project, actually with Dr. Kalantari. He's here, but he had to leave for a minute. And this is, we think it's a very unique project, of course, because it's our research, but really do think so. We're looking at VR as a way to enhance social engagement and cognitive engagement among older adults who have a mild cognitive impairment. And a unique feature about this project is we're actually pairing the older adult with the cognitive impairment with a non-impaired older adult who will serve as a volunteer in the program. So we will pair them up, and they will have weekly virtual reality experiences. We just looked at some of it today, in fact, in Dr. Kalantari's lab. They'll take a tour in New York City together in the 1970s. They'll do a wayfinding task. They'll do a creative task. So the point is to enhance not only social engagement and interaction, but also cognitive engagement. Thus, that's why we're giving them an array of tasks. We think we'll not only find hopefully some benefits for the older adult with mild cognitive impairment, but also for the older adult who is a volunteer in terms of benefits of being productively engaged and, you know, kind of serving as a support system to someone who has an impairment. And we're going to rotate. They're going to have this system for 12 weeks in their own home. And we're going to rotate. They'll have one volunteer for 4 weeks and then another volunteer. So they'll have different volunteer experiences. So we can also look at some of the characteristics of volunteer and patient matches in terms of what works well. Again, our process is pretty similar. We're just kicking off now an interview study with both volunteers and older adults to find out what type of experiences would be of interest for them to do together. We're going to do some usability testing of the VR products that are being developed in Dr. Kalantari's lab, and we're going to do 2 rounds of usability no, 3 rounds actually. The first with a very small sample to get some very initial feedback on the nature of these experiences. Then we're going to do a larger usability trial in the lab, refine the system again, and then a 3rd usability trial in people's homes with the actual volunteer before we roll this out for our larger randomized control trial.
So I'll mention Tommy's project. So Sarah and I co-mentor a trainee who is wants to look at the feasibility of a social VR intervention to enhance socialization in homebound older adults in New York City, where social isolation clearly epidemic. And to start the project, she's going to be interviewing key stakeholders to include caregivers of individuals, of homebound older adults, healthcare workers as well, and patients who are homebound to get at their perceived barriers and facilitators to using this kind of tool in the home environment, and that will be followed by usability testing. I would mention one other project with Anthony Young, who's not here today, but psychologist at Cornell Ithaca. We recently completed a study that isn't immersive reality, but is simply a web-based program to enhance positive affect in older adults with fibromyalgia, and showed very positive results in feasibility. And we're now looking for R01 funding for that one.
talking about challenges. If you care to comment on any of that, please do. If you don't, go on and talk about whatever challenges you're interested in, and then we'll open it up to the audience for discussion. Thank you.
Well, I think one challenge we've been, here's our part of our SERVE team. This is part of the team that's working on our one project that we saw the great work they're doing today. But part of our challenge is, of course, thinking about doing this in the homes of older adults. I mean, it's one thing to do, we're really putting ourselves out there in a way. I think it's one thing to do this in the lab where there's research assistants and it's very controlled setting, but we're really thinking about how can we do this safely in an older adult's home where they may not have someone there to assist them. So we have done very early on, we did a heuristic analysis of existing VR applications to look at things like, do you do them seated or standing? So one criteria we have for all of our experiences is that they have to be done in a seated position. And, we have to think about effective training, not only training in how to use the technology, but also safety training, excuse me. And then when we think about the volunteer, there's training for the volunteer also in the nature of the interactions and handling perhaps challenging interpersonal situations. So I think, the challenges go way beyond just putting a headset on some. Certainly there are challenges there. Does it fit? Is it too heavy? Can they operate it? But I think there's a lot of contextual, environmental, both physical and social things that we have to think about.
I think our main challenge in the laryngology clinic is that we have many uses and applications that we're seeing, but we just don't have the partners, but maybe this will change after this conference, to really create the applications. And we have plenty of very unique situations that can actually be helped with VR because we're used to working with speech and language pathologists who have a behavioral approach to management for patients' conditions. So it's really ripe for applications in VR. So if you're interested in voice, airway, cough, swallowing, please reach out.
A challenge that we face often is a balance between either using commercial apps that already exist versus custom apps that we have a lot. I think the easy way to go is to use commercial apps, for example, to promote social connectivity and social connections. You can use something like VR chat, but VR chat is kind of the Wild West of the internet back in the day, where it's uncontrolled. You have people from all over the place, young people using language that maybe our adult participants don't want to hear. So I think there's a challenge with a lot of great apps out there, but they're not designed considering the need. So we have a development team with then I think that balance. Something figure out that balance.
Challenges to share. One is at the patient level, recruitment can be a challenge at times, and certainly having people understand the value of participating in research is key, and getting other stakeholder groups to suggest that this is an appropriate thing can be helpful. At a system level, we see IRB issues at the medical college being a huge issue and slowing down research. And those can be hard to overcome. So those are two.
I'd like to mention one more, which actually Dr. Reed alluded to when he was giving his talk, and it was one of the challenges that you mentioned, was that this technology changes so rapidly. So when we originally wrote one of our CREATE grants, for example, I think it was we put the MediQuest 2, right? And now we're up to the 3 or the 3S. And so, things that they're not significant changes, but they require changes in protocols and in development work and budget.
Mhm.
The other thing is these things are expensive. And so running a trial with 200 people, we're going to have to recruit them in waves and rotate the equipment through. And I know Dr. Kalatari's been working hard with this MediQuest company to try and get them to assist with the cost of this technology. I think they went down a couple of dollars, right?
So I'm going to be the mobile microphone. Wow, that's loud. And circulate among the audience to see if they have questions, because I know that the panels are tragically short. So I want to make sure that if folks have things they want to ask, I can bring the microphone to them. I see 2 hands, so I'm going to go to the closest first, and I'm going to turn around to make sure I'm not neglecting the people behind us.
Thank you, Andrea. All of them fascinating projects. And I mean, I'm not just the only one excited in the room. I just got the microphone first. I'm going to go to the IRB part because I think that's the real pain point. Technology and all of that, after the symposium, I think we're going to be able to address some of the resource issues. So how do we get something that is an MVP or a pilot or first step to the next step that is the scalable / translational / how do I bring this in my clinic in the same way that I use care? And what is the pain points? Is it something that, is it a security thing? Is it a technology? How do we bring IRB to the level that the same way that we have clinical trials with drugs and they have toxicity, VR headsets are not that harmful? So what's your take?
I think it goes beyond the headsets, at least our experience. A lot of it is about privacy and security and sharing of information. And hopefully there's no one from IRB in the room. But I really think it's also a matter of education. They don't really understand the nature of what we're doing. They don't understand usability trials. It's that the mindset is biomedical drug kind of trials to a large extent, or cancer or something like that. So when we're talking about behavioral research, a lot of red flags go up, and I think some of it's from the lack of understanding. And now we have another layer at the medical school. So anything that involves technology is kicked now to another some committee.
Digital health technology.
Digital health technology, who has to review it, and then they send it back to the IRB. So it's a whole other layer, and their primary concern is around, I don't know what, privacy, data leaks. Uh-oh.
Then we, had quite a bit of problems getting any studies off the ground because not only did the equipment say that, but then we wanted to work with children and adolescents in the area of pain. And so I think I don't think there are any lawyers in the room, but if there is someone that can educate us on the IRB and there's the obvious one of HIPAA, the privacy, and like voice as a biomarker. Then there's a risk of the equipment, will an older person fall? Will a younger person overuse it? And so I think there's a whole layer of infrastructure behind everything we all do every day, whether it's on the clinical side or the clinical research side, that involves the law. And that's something we probably don't talk about enough. I mean, I do think there are other issues, Alex, like the infrastructure and getting the equipment to harmonize smoothly with the huge infrastructure of equipment and all real safety concerns like infection transmission and whatnot. But I do think there's this other layer that we don't really talk about. Probably my 2 cents. Well, what? There's a reason I invited Doug. I, 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 I I can't quite hear you. Are we talking about the IRB or are we talking about the infrastructure now? Oh, I know. Doug's been at this for years, and I'm really excited to hear what they have to say in the next panel. So we're not expecting too much of you, Doug.
All right, for Dr. Boot, I have a question. What, from your usability or preference study, what did older adults prefer?
So I think that the most preferred apps were ones that there was Meta TV, I think it's called, or it was like a YouTube. It's almost it's a VR YouTube type of application where you could just be immersed in a video. You could see a concert. I think one of them was a tour. See a concert. So yeah, so those were I think within the top five. It was more culturally oriented VR apps that were immersive. The ones fishing was one of the ones that was least liked. I can tell you that fishing was kind of low on the list. But what really surprised us about that study is that we had people rate these things on kind of a 1 to 5 scale, 5 being most enjoyable. Almost every single app, the average was above neutral. So most of them, this was one of the challenges of the study, is that most things fell between 4 and 5. I mean, it really goes against this, I think, false notion that older adults are technophobic. They hate technology. They're afraid of technology. But we find that we have to turn people away from our studies, that there's so much interest in these VR studies that we just have to tell people, we'll put you on a waiting list. So yeah, yeah.
Just a common theme here, which is the study of the older adult. And there is ageism in research where, people don't think about recruiting older adults in their samples. And I think there's a fair amount of research that suggests when they look across age categories, older adults are very adherent when they get in these studies. So just consider older adults out there recruiting.
And regarding older adults, because we also see them in ENT clinic, having hearing impairment is a big issue also in using a lot of these tools. So thinking about that in your design is very important.
One other comment about our preference study. We had 40 people across 2 campuses participate, and we did not have any problem with simulator sickness at all, cyber sickness.
Well, that actually is remarkable.
Yeah.
And rare. Well, in order to stay on schedule, I'd like to thank you all very much for your participation today. It's a really enlightening panel, and hopefully we'll all get a chance to talk to you some more during the cocktail hour and poster session, a little more informally.
And those workshops coming up tomorrow.
And the workshops coming up tomorrow. There's lots of time for more informal discussion. Now, if the next panel group of panelists would come up, which is going to be on medical education. Well, they're coming up here. I just want to say on a personal note, back in 2004, a woman who became our dean, associate dean for med ed, Yoon Kang, who's now gone on to another university, approached me about using virtual reality in medical education then when we first began our World Trade Center work. And ever since that day, that behind the scenes, people have been working to try to figure out a way to integrate virtual and now immersive technology into medical education in a way that was cost effective, measurable, and interleaved well with the infrastructure such as it is. And in the last few years, I know Doug and others who are not represented today, and some of the people on the panelists have been working to make that happen. So with that in mind, I'm just asking you all to do the same thing. Please introduce yourselves, talk a little bit about what you're doing in medical education and the opportunities and what the challenges are. And Doug, we're going to be peppering you with questions about how to make it work in the infrastructure. Thank you all very much for agreeing to participate.
I prefer for last.
Let's start.
Hi, everyone. My name is Rohan Jatwani. I am Assistant Professor of Anesthesiology and Pain Medicine at Weill Cornell Medicine. So I guess to start, I am a practicing clinician. I practice both anesthesiology, so I'm up at 3 a.m. at night dealing with anesthetic emergencies. But I also have a pain clinic and I treat pain patients and I prescribe VR to my pain patients. So a lot of intersectionality here from what I'm hearing from everyone. And I also train the gamut of all kinds of healthcare trainees from their first day in medical school to their last day in fellowship. In fact, I feel my phone vibrating, so it must be one of my fellows right now trying to get answer a question that's coming up in clinic. So I have the privilege of being the co-director of a group within our department called XRail, the Extended Reality Anesthesia Immersion Lab. We have a couple of missions. The first thing we do is we train our residents in extended reality. We do this for hard skills, and we also have started to do this for soft skills. So we actually develop our own AI conversational agents, and we can talk a little bit about that. I had a fascinating conversation with our AI conversational agents about end-of-life care last night when I was developing it. And we have grants that fund this from the ACGME and other sources. I have a small endowment from the medical school, and Doug serves as my mentor for that work, where we try and scale these so that everyone can benefit from this kind of learning. And then lastly, we are also doing our best to try and take all the advantages when it comes to pre-procedural planning. So I actually do create 3D models of my own patients before I go into the operating room and do a procedure, because I believe it's the right thing to do. If I can do a procedure safer, faster, better for the patient, and we have the technology to do it today, we got to do it. So, and then lastly, just a small plug. There's actually all the stuff that we're talking about today. It's ripe for publishing, and we run a small journal. Professor Tafiti's involved, and so is Professor Wan, the Journal of Medical Extended Reality. So if you want to write guidelines or you want to take all this knowledge and share what you guys are doing, please. I'm always ears for that kind of stuff.
Hello, everyone. From me, I'm Alex Garas. I'm an assistant professor of research at Weill Cornell Medicine in computational biomedicine and physiology and biophysics. I also direct the AIXR lab here at Weill. And I'm coming to the medical world from the journey of the scientist, working on a daily basis with our clinicians with a translational goal. So the two institutes that I'm affiliated is the Englander Institute for Precision Medicine and the Institute for Computational Biomedicine. And we're trying to find big data-driven tailored treatments that we're using tools such as AI and XR to achieve. Coming initially from a scientist realm, we're trying to make sense of the data, but the last mile is where the clinician gets involved. Like this guy, this guy. And John and you really are the people that are the one that helping make impact for patients. And we are to inform and create these technologies at the Institute on how we can help inform you to make the right decision, right? So a lot of the work, and we have some slides later on, focuses on one important thing: how these immersive technologies can reach the hands of our patients directly, whether they are wearing the headset, or indirectly by informing and making, like the same way that you think of the super soldier, think of the super doctor, right? Think of this mentality and how we can make Rohan and John and the rest of our Weill faculty strong enough to deliver a better care. So I'll pass it to that.
Hi, everyone. I'm Doug Cohen. If you didn't guess it, I'm in the IT organization. But outside of IT, I am also an adjunct to liberal arts education, technology education. So my goal, I think, is great. If we want to make the super doctor, I want to be one little element of support to do that. And so what we're looking for is ways to help general education principles and bring working with the experts to bring the content. So don't know the structures of the human body. So we work with the faculty using collaboration earlier to make sure that it's accurate. And then we get best practices in education and technology to make it current financial climate also we are looking at immersive in any way you can think, both 2D and 3D, interactive content. So we're touching on virtual reality, augmented reality, general interaction and manipulation, because a lot of the content that we've seen has just been static on a page or on a page.
I'm John Rubin. I'm also assistant professor of clinical anesthesiology at Weill Cornell. And I work with Rohan. I'm also the co-director of the extended reality lab we have, but I carry a number of different hats. I'm also the director of simulation education for our department, which is a big deal in the anesthesiology sphere. I'm also the assistant director of education for academic assistance within our residency education. And so just to try and add on to what Rohan was kind of talking about, I mean, for me, I think of using extended reality in a couple of different buckets. So Rohan and I think about hard skills training in terms of procedural planning. Rohan and I, as anesthesiologists, practicing anesthesiologists, he's a chronic pain physician. I'm what's called an acute pain physician or regional anesthesiologist. We do specific procedures, needle-based procedures, injections for patients who have pain. And so classically, the way that people learn how to do those procedures is reading something in a textbook or looking at an image in a textbook, and then going and carrying out that procedure under the direct supervision of an attending anesthesiologist. We think that there's a better way to move forward with that. Obviously, that apprenticeship model will always be true and always be crucial, but if we can prime the residents in advance by helping them to better understand the three-dimensional aspects of those procedures before they practice on the real patient, to give them greater comfort, then not only will they perform the task better, but also the patient experience will be better as well. And obviously talked about doing 3D reconstruction with DICOM imaging and so forth as relates to sets of procedures. We also talked about soft skills training in terms of using basically generative AI and conversational agents to create virtual humans who can exist in multiple different ways. One is for as basically a search engine. Another could be to better learn about a certain patient experience, like the experience that one embodies when they have a certain chronic pain condition. The other thing that I think about a lot in the context of academic assistance is standardized patient encounters, which every single medical student, resident, and fellow has to carry out and take a part of as part of a board certification process. And that is a very highly intensive process that involves actors and training of the actors and also things like that. Can we use generative AI? Can we create our conversational agents to both act as a standardized patient and also to grade encounters through its advanced linguistic properties, and then to provide feedback to our learners? And I think that's a very complicated thing. We'll talk about that more, I'm sure, in detail in this panel. But, you know, where I come from is obviously we need to have guardrails in place for conversational agents, and Rohan and I are writing the guidelines for that for our journal. But, you know, we also need to be able to have people be successful and also people fail in these encounters. We need to both know who is doing a good job, but who is doing a bad job and the reasons why they're doing a bad job. So it's not as straightforward, I think, as we all think. There have to be these very nuanced arguments.
I am professor in human-centered design here at Cornell, Ithaca. I'm also the director of the Duet Lab, which is designed for user experience technology lab. So my background is design, especially space design. But I have been always, it's been more than 2 decades using virtual reality. And like 5, 6 years ago, we had came with my colleague who I became good friends with, a medical doctor and group of doctors in Korea. It was almost like accidental. We talked about service quality, how we can make a patient experience or customer experience better with the virtual reality, immersive media. And then the colleague became the member of Severance Hospital, which is one of the big 5 hospitals in Korea. And then they came to me and we actually talked about how we can do some fun research together. And then they said, they have a group of people actually had a similar idea. You know, when doctors, especially in the doctors in radiation oncology department in breast cancer center there, they said their job is to help the patients, but when the patients learn about they have breast cancer, then they have to explain what kind of procedure they're expecting. But that's not part of their, it is their job, but it becomes hugely stressful because they have to explain this detailed and also complex procedure steps and to the patient who are already very anxious. So they explain patiently once, twice, and then their caregivers or family members come and they ask the same question and they have to explain, and they cannot go like a fast because it's a very important information. Then they need to be sincere. And then it doesn't happen just in the doctor's office. They ask the patients and their family ask the nurses too. So it happens like multiple times per patient. So it is important for them to be professional, but at the same time, they have to spend their time and energy more on what they actually have to do. Treating patients. So they wanted to develop something to help the patient to learn about the complex procedure so that they don't get too anxious, and also they can watch over and over so that they are completely familiar with the procedure, not only just the patients, but then their family members. The family members who came to the hospital with them, or family members who could not make it, but they still want to learn about the complex procedure. That the complex the education not only covers the steps, but also we can take them to the space, what kind of machine they will be using and where. And so I was actually modeled there as one of their video production too. So I learned how complex the procedure is. So it's almost impossible to process all the information in one meeting. So we decided to do this study so that we can test how this experience or this experience for the patient can help to perceive the service quality, so that when patients have choices, they can come back to this hospital. So the idea was really good, we thought, and that's definitely, we're gonna find something very significant, and also will help the hospital. But we had the first hurdle, just want to develop the package. So it was one of the big 5, and then those teams or companies producing this media package, they charge at least $30,000, $40,000. And I thought, what? So we didn't have the budget, right? We had a cool idea. We wanted to work with each other. So I ended up doing it for free. But it was my summer project. In the end, they came up with some grants. So it was overall, it went fine. But so with that project, we recruited about 200 patients, and it's a randomized trial. And then it's published, it was already 5 years ago, but it published recently in International Journal of Radiation Oncology Biology, physician, I don't know, biomedical journal. So, and also beyond this publication, this became the promotion package for the case for the hospital. So a lot of media coverage. So the group became very famous. I mean, it was good turnout. At the same time, what we found, the patients, they are just more satisfied compared to the other group, control group. And anxiety reduction was significantly improved. And the doctors, we only had 2 doctors sign up to be the model in this media, what they call stimuli. So we could not test the doctor who's going to be in the video. We wanted to test that matters too, but we didn't have a chance to study that. And also, perceived service quality was improved, and anxiety reduction impact. Short term, it was clearly significantly better, but long term effect, it's inconclusive. And we wanted to study. We wanted to run more studies, but again, who's going to develop that again, right? So that's a kind of dilemma, but the effectiveness was very clear and the patients were happy, and then doctors, nurses, they didn't have to deal with the anxious patients after just one time explaining the overview, because in this video package, the VR package, the doctors are showing their best, right? They're acting really well and very thoroughly explaining every step with the visuals and take the patients through these different spaces and then explain all different machines. And then the family members, they can watch through video, not the goggle and the VR headset, versus the patients at that time. The first time they have had to walk through the experience using VR headset. So it was overall very cool project, and it was rewarding experience. At the same time, we were not sure we can do it again because, again, where is the budget? So that's a limitation.
This might be a good time to look at the slides to get an idea of what everybody was working on. So I don't know, Dr. Yin, if you have images of your slides. I think we have some.
I sent you the link.
Yes.
Two links.
So are those?
Let's roll over to see if these are mine. Yeah, keep going.
If you could talk about the slides that we have up now, and I'll re-forward them.
Yeah, I can talk about the slides. So I'll try to keep it brief. Basically, this is 2 examples that we've been doing XR at Weill. The lab has been for over 10 years now. This was a project that we did with Weill Cornell and Weill Cornell in Kitov. 4th step that we often, forget because time zone, it's too late there. It doesn't matter. So Dr. Salama, Suher, Raouf, Algerti, and whom else I'm forgetting? Oh, and Sandy. Where is Sandy? There. So we worked on one fundamental problem that we have even here. We say, oh, it's too far to collaborate. It was 230 miles to get here. Doha is over 6,700 miles. It's very easy actually to work. So VR is breaking the barriers of where people should be. And one of the things that we were looking into was with problem-based learning, in a quick show of hands, who's a student here? Students, okay. And who is an educator that has gone through problem-based learning? I mean, all the clinicians, right? So the biggest challenge that we had during COVID was problem-based learning is something that you usually learn in person. And going to these Hollywood squares where the Zoom or Teams greatly diminished our problem-solving capability. So with the team at Doha, we said, what if we were to meet in the metaverse, in this embodied sense that Andrea talks about, and see how people would react? And we gave the space, and people would get added in this large seat, and we did this into a trial, trying to gather data, whether the students would prefer or not being involved into actually meeting in the metaverse. And we actually demonstrated that it is more meaningful meeting in the metaverse. And, you know, the cool thing that comes out of it is it is almost impossible to get taught with someone that is faculty at Weill in Qatar or vice versa, or have the knowledge exchange or even the cultural exchange of how you would approach patients, right? Or your troubleshooting when you're dealing with a completely different continent. So bringing these two together really reinforced on what we can achieve. Now, the second one, and I don't know if the screen sharing or not, I think we're troubleshooting. This is a project, and if you could switch. So this is a project that is with cardiac interventions that we're doing with Dr. Mosen. And we are also working, where's Mosen? So Mosen has a poster over there. And whether you talk to Sandia or Mosen, they would tell you more about it. But it solves a very fundamental problem that not only the cardiologist has, but I think it expands across all surgeons. So there is this mantra in medicine that says, see one, do one, teach one, right? And for the person in the cardiac interventions, there's not really something other than, okay, you get to see me do one, and then you get to do it on a real patient, which the first time that I heard was, what? It's kind of horrifying. So VR can play a key role in easing that method out. And the part that Mosen will also cover, not from a just medical education standpoint, but a translational value, we are seeing that in comes AI, and from 2D we can give 3D depth perception. So the cardiologist or the surgeon essentially can see depth perception and can navigate much better and can get to the desired goal much faster and can reduce the time that it takes you and John already know you're the anesthesiologist, that you have to be there and, support this. So these are two examples that I think XR has played a key role in medical education. I mean, the team has a plethora of things that are, equally valuable or even more. It's just at the beginning.
I think, well, when you say it's just the beginning, that's very apt because I think you all will be here for the poster presentation. So look at everyone's faces. I know we have a couple more slides on both ends. It might be good just to run through quickly before we go on to the next panel, just so everybody knows what to tackle you about besides IT issues. Doug.
Doing that.
Really 1 minute left. Let me show you a little bit about what we're developing in our group for the residents and the med students. So this is an example of us, much like Professor Sagaris was talking about, being in a shared space. So we have our models. We can point out in the models where the pain is happening. So in this case, I'm trying to point out this is the distribution of the occipital nerve because maybe a patient is presenting with occipital neuralgia. But something that we actually, and so there you can see Dr. Rubin, who's like a virtual embodied surgeon with a stethoscope and everything in virtual reality. We're actually in different, parts of New York City, but connected together. But we also have tools that we actually don't have access to. And one of those tools is like a 3D splicer. So we can take a 3D splicer and do things that we can't even do in a cadaver lab. We can, in real time, show a 360 split of the anatomy and draw where we think that the nerve in question that we're trying to get to is. So that's one example of something we can do. We actually have many times brought these headsets into clinic. So something John and I fundamentally believe is that education doesn't just happen in a sim center once a year. The education has to meet us at the moment we need it for the right patient. So we bring the headsets to clinic because that's where the residents need to learn, right? Before they do the procedure, not 5 months before, and maybe they get to meet the patient at some point. And these headsets go everywhere. They're not like $1 million sim center that's, that you see once a year. And so this is an example of a publication that we did about how we're actually doing this in clinic. And we call it point of care, just like we do with other technologies, but point of care extended reality. This is an example of a new technology we're looking at where actually we can create 3D virtual boards, and you can see there's an operating room. It goes even so far as that John, who does a lot of things very well, actually, but has never put in a pedicle screw, can, with the use of a 3D fluoroscopy machine, so an X-ray, a 3D hammer, a 3D screw, and you can see that in time, as John is hammering away, the fluoroscopy machine, and you can see him actually like turn the screw into the pedicle. Like this is real. We are actually doing this and trying to teach our residents in real time to do complex spine surgical procedures, all from the comfort of their homes. And then you can have a teacher and a mentor guide. Something we're working on for the med students who are just learning, we can actually create N of 1 spaces that can, like this is in my apartment. This is a test where we have 2D video with 3D objects, something that Doug's very excited about. This can go into any classroom. So any classroom can become a virtual museum to augment whatever they're learning in their lectures. Lastly, the picture of us with Carl. Carl stands for Conversational Agent Relief Learning and Pain. I'm going to look at my medicine colleagues. Carl is a patient who lives with very severe pain from sickle cell anemia. And this is a huge problem in every hospital I've ever been to. Patients who have sickle cell crisis come into the hospital, often feel like we're not listening to them. So we create models of that experience, and we make sure that our residents understand the nuances of talking to these patients. And the patient and the virtual agents are able to adapt to their stories pretty incredibly. So I won't show you videos of that because we're out of time. But if you want to meet Carl or you want to meet other agents like Carl, we have them. We can show them to you on our laptops.
Do we
and our
have
headsets.
are you a part of demos? Are you going to be demoing that during the
We
coffee?
certainly
break?
can.
That's
Certainly
amazing. Okay, and I do think we have one more video for you.
So you
Or more, do we have the slides for Soyeon? Okay. And then we will go to the next panel. Yeah, the slides that I forwarded from the middle, from the most recent slides that I forwarded that were from late last night.
It's a YouTube video.
Oh, there we go. Yeah, perfect. That's it.
So you can,
겠습니다.
headset, and you can,
치료 전반적인 과정에 대해서 먼저 간단하게 살펴본 후 각 과정마다 자세하게 설명하도록 하겠습니다. 병의 상태, 체형, 몸 상태가 모두 다르기 때문에 외래 진찰을 통해 어디를 치료할지, 몇 번을 할지, 어떤 기법으로 할지 등의 방사선 치료 계획을 세우게 됩니다. 진찰이 끝나고 나면
it's not 3D, it's a 360 panoramic.
People were viewing it in the headset.
You can explore. Have to walk around.
So just to explain for people in the audience, if you haven't seen it on desktop, you're mousing around on the touchpad, but if you were wearing the headset, you would just be going like this, just
Right.
looking around. So I wish there were time for questions because I'm sure you all have a lot of questions. Observe the faces of these wonderful researchers and tackle them in less than an hour when we're going to the poster session. And thank you very much. Okay. I'm super pleased while we solve the last slide problems to have our next panel on remote healthcare applications. And I'm going to say if we, I don't think you had slides, so if you want to just introduce yourself, Dr. Cole, and tell us a little bit about your work.
So I'm Kurt Cole. I'm associate professor of clinical medicine and population health sciences at Weill Cornell, and I am the chief global information officer for Cornell University.
Hello, everybody. I'm Michael Turman. I am an instructor of psychology and psychiatry. I'm also a practicing clinical psychologist. I have the good fortune of having Dr. Dr. Stevenson.
Abe Davis. I'm an assistant professor in computer science here at Cornell and Ithaca. My group works on kind of a mix of topics spanning computer graphics, human-computer interaction, and computer vision. And maybe I'll say a little bit more about that after all the initial introduction.
I mean, you can. I'm Alex from before. So.
And you also are in control of the laptop. So I think we have a couple of videos from you. Michael, we've shown off the environment. So when we go down the row, we can remind people of that. So do you want to kick us off, Alex?
Yeah. So which order do you guys want? I'll just take the first. So should I just quickly go through?
Yes,
So
please.
we're talking about essentially two examples of in this panel that we have used. And one of them is heavily inspired by what transpired in New York during the height of COVID. So all the people that you see here, Cynthia Kane, Dr. Liu, Dr. Weir, Dr. Beck, Dr. Mosquera, Dr. Andreopoulou, are the healthcare heroes that stepped up at the height of COVID. And what happened was I got a call like March of 2020 that my staff are there in the lab, and everyone in the lab was isolating. The people that were at the front lines were only our clinicians. So Microsoft sent me HoloLens 2s, and we worked with a team to put them into good use into the front lines. And at that time, Kurt, your team had been instrumental in cutting a lot of red tape and getting them HIPAA compliant and getting them across. And we reached out to Microsoft and we got more devices in kind, and we put them in the MICUs and we put them into the wet labs, and we put them in areas where they really help make the connection and connect the team that was on the front lines and the other team that was isolating that Cornell had been severed off. So think of like you only have half of the brain, or you have a little bit of the brain, a little bit of the muscle, and you're missing the other part of the team. So some of the work that we had done back then was how we could leverage that technology, how we could leverage XR for remote collaboration in the health workers during the COVID pandemic, just to give an example. The other one that we did with Dr. St. George, Dr. Peter Greenwald, Dr. Lane, Dr. Pertenko, Dr. Davidson, Dr. Balasubra, I always say it wrong, Shriman, and Neil, Dr. Bavsar, and Sandhya, of course, was how we could use this in emergency medicine to teach endotracheal intubation. So we our emergency medicine residents at Cornell in Weill are affiliated with NYP, and the sister institution is Columbia University. So the first year medical residents in emergency medicine are both Cornell and Columbia. And we decided to do some, what we would call in computer science, alpha beta testing, or like a feasibility study, to see whether the golden standards that would be to teach in the tracheal intubation, how they would fare comparing teaching this in mixed reality. So what you see here is the beta or the alpha or whatever you want to call it, that basically you have a senior resident instructing the first-year residents how to intubate. And the logic there was in the see one, do one, teach one, was that you get a 30-second onboarding on a HoloLens. You had to construct a solo cup pyramid just to connect the instructions that people would give you with the motor, kind of like the neural motor, like. And then you would follow these mixed reality tutorials, having Jonathan up here and giving you instructions of how to intubate with that 3D models, beautiful media that the PAC group has created. And then you would have the senior resident assist you, and you'll see a short clip. And then you would be straight. It's like a conveyor belt. You would be straight to evaluation, and then you're good. You know what emergency medicine requires, you know, immediate actions right away. And you'll see Neil.
Yeah, and then hard palate and then soft palate back there. So now I'm going to gently go in side, gently sort of lift while not applying pressure on the upper teeth. I see the epiglottis.
And this time you can look up at the glottiscope so we can see your view, the monitor. Yeah, perfect. Perfect. So I see great view. Yep. Now you want to be a little bit further into the vallecula and then lift up as you're in the vallecula. Great. Now look, you have a great view. You got like 100% view of the cords. Now you can use your right hand and just slide the tube through along the blade.
All right, I'm gonna make
Great
sure
job.
that
Yeah, keep pushing.
Going through the trachea beneath the cords, make sure the balloon is beneath the laryngeal cord, about like 2 or 3 centimeters. And looks like I'm in.
But I would say in this particular scenario, what happened is we first did this in the front lines without an IRB, immediately trying to create this SWAT team of amazing clinicians providing care for our patients. And then after the pandemic kind of improved the situation, we went back to the drawing board and we said, what worked well, what didn't, and how do we do the proper IRB, the proper journey into making this part of our syllabus. And this is now part of our syllabus. So these are the 2 examples that I added. Abe, did you?
Yeah, maybe I'll say a little bit before.
Yeah, of course.
Yeah, so, you know, like one thing that's kind of remarkable about a lot of the work that's been described here is we're sort of building on technologies that were primarily designed for a different purpose to do, you know, remarkable things, but remarkable things that sort of weren't anticipated in that initial design, right? And this happens at both a hardware level and often at the level of software that runs on that hardware for things like tracking, for example. So like anytime you're trying to do some application where a device needs to know where it is in 3-dimensional space, then there's some kind of tracking that's going on. And that tracking wasn't really designed for medical applications. It was usually designed for games. So, you know, my group is in computer science, and it's sort of a mix of, you know, people who would consider themselves computer vision, people would consider human-computer interaction, people consider themselves computer graphics. And part of what we try to do is think about how do we identify aspects of that sort of support, you know, things like tracking, things that are part of APIs but part of APIs that were not designed for these medical tasks. What are ways that we can redesign those where we're re-implementing some of the foundational algorithms that are usually taken as a given as APIs that will allow new, more or different applications or improve the downstream applications. So what I'll show here is a video for a paper we recently published that was led by my student Jan over there, who you should definitely talk to. And the idea here was that on mobile phones, tracking is designed primarily, again, for sort of entertainment applications, which means it assumes that everything is rigid and that its appearance doesn't change. And this makes it really poor for tracking sort of arbitrary parts of the body. And so in this application, the idea is we want to be able to track something like a wound or some part of the body as it progresses over a long period of time. And we want to be able to factor out all sorts of changes that might not actually have to do with the body itself. So things like, changing lighting in different environments or the exact pose, position, and angle of a different limb. And we want to sort of be able to factor all of those things out to provide a consistent view. And we want this to be something that users can use in their homes, at their office, they can use anywhere, anytime. So I'll let the video maybe do the rest of the explanation and Jan later on after that in the poster session.
The human body is constantly changing its shape and environment, which can make it very difficult to track slower, more subtle changes related to growth or the formation and healing of wounds. But these slower changes can tell us important information about our health, which is why in clinical settings, there are strategies and tools for collecting data that make tracking these slower changes easier. Unfortunately, most of these solutions don't extend to remote healthcare settings, where all most patients have access to is a mobile phone. So to address this problem, we introduce a mobile application that helps users capture personal time-lapse of the body. Our custom tracking and interactive guidance makes it convenient for users to capture data in different environments and compile it into high-quality, consistent visualizations of the body over time. For more information and a link to our free iOS application, check out our project webpage.
Or ask you at the poster session?
Yeah. Yeah. And I mean, Jan can show you how to use the app.
So you should raise your hand so everybody knows where to find you. Okay, so actually I think that's a perfect transition. So Michael, we presented the project you're working on, but you have insights into engaging with patients. So tell us your thoughts.
Yeah, I think there's two main things that I've been thinking about with this. And one of them is really bridge that a little bit too, and to think about how just remote application is. In any exposure-based therapy, I look for patterns, engagement, natural-based exposure. How does going through. It's great if we could get that. So citing sort of this code that they're working up, and the patient and the respiratory rate is increasing, the vital signs. They look at trying to ceiling, a medication cabinet or a Pyxis machine. All of those are typical out. So I think that's been just one example of how we've taken this.
So that kind of backs up actually what you said, Abe, about in tracking in a different way, where you're using the tracking abilities to look at change over time. And in this case, you're using tracked behavior to identify changes in state of mind. So sort of a flip. I want to leave time for questions, so I want to go on and talk to you or ask you to talk about your thoughts on remote healthcare application.
Okay, so I want to begin just by telling people I am a technology optimist, okay? And I do have pretty strong history of successful implementation of pretty complex technologies in my career, such as the EMR that we now have at Cornell and New York Hospital. But I am going to make a bunch of now very negative remarks. But I will, but I promise I'll end on an optimistic note. You know, I spent a lot of time mentoring students and faculty who are trying to bring up technology companies. And I think there's two critical things that you need to keep in mind as you develop a technology. And that is regulation and reimbursement. And those are the two primary obstacles to innovation in America, okay? But if you are thoughtful about them and you are opportunistic and following changes, and guess what, we're about to have a lot of them, that can present opportunities for success. So I want to give a couple examples of what I mean by that. So first of all, regulation gets a bad name in our industry. We always talk about how it blocks things. My mentor was Joe Hayes, I think one of the greatest doctors ever to practice at Cornell. His first job, he was a technology visionary in the 1960s. He ran the Heart Station, which was EKGs. They were cool things in the 1960s. And one of his first problems that he faced was that the technicians told him that the patients were getting shocked by the machines. The reason they were getting shocked was because when they built New York Hospital in 1938, they didn't ground the building. Okay, that's now required by regulation. That's a really good thing. All right, so we need regulations to keep healthcare systems safe, but that feels like an obstacle to an innovator. But we do first try to do no harm. So try not to kill people, pay attention to the regulations. Where I think we have serious problems that we need to work on in our is with liability. And remember, it's the physicians who carry the liability, and that is a huge issue. We have a lot of really cool companies that have tried to implement it at New York Presbyterian, and they get slapped down immediately because the hospital says you have to carry hundreds of millions of dollars of liability insurance, which is not practical for a startup. My advice to those of you who want to succeed in that space, stick to research for as long as you can, because as long as you are covered under a research umbrella, you can prove the viability of your product before you actually have to become commercial, at which point you have to carry liability. Okay, so then the next thing is reimbursement. A lot of companies fail early because they fail to think about who's going to pay for this. And so the reason that remote care is a success today and was not a success 10 years ago, even though we've had telemedicine since the 1960s, okay, is because reimbursement changed under COVID.
And with that change in reimbursement, where we actually paid doctors to take care of patients remotely, we learned all these cool things like Medicaid patients who can't afford to pay for the subway can show up to a remote appointment from their house. And we actually saw increases in compliance with some of our poorest and most difficult to access patients because of remote care. That's really cool stuff, but it comes down to not understanding the reimbursement environment. Where we see success right now, post-operative care. Okay, so one of the earliest virtual implementations that we had at Cornell was in ophthalmology, where patients used to have to come back to the hospital after surgery to get an eye test to prove that they were healing correctly. Now they can do that on their iPhone without ever leaving their house. Why can we do that? Because surgery has global payment. The doctor already got paid. Okay, so they don't have to bill again. So understanding the field that you're in and how it is compensated is very important. That's a particularly depressing subject in the case of mental health, which is so horribly compensated in this country. And actually a very serious barrier to virtual care companies, because they often need a human in the loop and there is no one. Like, I mean, I'm a primary care physician. I can't refer to people because there's no one who will see these patients. So that's another. Okay, I'm understanding. I'm short on time.
You're perfect.
So, but I want to make one optimistic point. Okay, so now working on a project in Brazil. It's a project called Open Care 5G. The country is investing in improving their networking infrastructure for the entire country, the telecommunications infrastructure, hence the name 5G. It is actually primarily a satellite-based implementation, which you may have read about because Elon Musk refused to follow Brazilian law, and the whole thing almost collapsed because it's built on Starlink. But he did finally agree to follow the law, and now we're back on track. So they're using satellite to deliver telecommunications networking to remote areas of the country. And Brazil is a very big country with a lot of poorly populated areas like the Amazon. What they've done with remote care is that they have very few doctors in these areas, but in places like Sao Paulo, they have a lot of doctors. Sao Paulo actually has more doctors per capita than New York City. So I work with the University of Sao Paulo, and they send technicians up the Amazon on a boat. They were doing this with pregnant women. They do a sonogram using a portable sonography that can actually be powered by an iPhone, send it up back by satellite, goes back to USB, gets read by an obstetrician. And they were able to improve pregnancy outcomes for women at an extremely low cost. Why does this work? Because in the country of Brazil, healthcare is a constitutional right. So when the country spends money building their telecommunications infrastructure, they immediately think of healthcare. So this is I do practice medicine and I do research and teach, but I'm primarily a bureaucrat. So that's why I'm asking you to contemplate these bureaucratic solutions that we have to fight for. These innovations that the people in this room are building are really cool, but we have to get over these reimbursement and regulatory obstacles in order to actually succeed with implementation.
Thank you. I cannot resist opening to one question from the audience, and then we'll pull the panel up. And remember, you can track everybody down. That was a beautiful sort of summary, but that we could talk to each of you for another half an hour. But one quick question. I think this means everybody thinks they're going to buttonhole you at the reception. So we're going to let them do that. And I'd like to invite the next panel up. Thank you so much. Really fascinating stuff. Okay, so this is our last panel of the day. And I think we can start. Well, we've already introduced two of the panelists, so I'm going to go to the middle.
My name is Wendy Ju. I'm an associate professor in information science at Cornell Tech. The focus of my research is looking at how people interact with automated systems. A lot of the work is looking at how people interact with robots, autonomous vehicles, do a lot of field experiments, for example, in New York City, where we are. We have done different projects in the healthcare space through the ages, but like really, I think it's a little bit less my area. But right now we have some perspective work that we're doing with Joel Stein at Weill Cornell, looking at how to use VR to help people who have gait freezing, people with Parkinson's gait freezing, to kind of unfreeze their gait in a physical therapy.
So I guess that I kind of want you to talk more about that, and then we can go on to the other projects related to agents. I know you have a poster up there, but maybe if you could talk a little bit more about your work, and then we can go to Soyeon and then Alex.
I mean, with regard to the topic, I do a lot of work in immersive virtual reality simulation, particularly look at how people are going to interact with future technologies like automated vehicles. Of course, we have, there are automated vehicles on the road. We could go and study how people are doing deployments with, I guess not Cruise anymore here, but with Waymo, for example, in San Francisco. But a lot of times what we want to know is things that don't exist yet. Like what if this, interface was different, or what if the car moved differently? And so we use a lot of a lot of immersive technology to simulate those environments. And what I try to do as a focus in my research is not just do driving simulation, which is immersive, which I think we've done some leading work using VR headsets for driving simulation to lower the cost of driving simulation setups. But what we try to do in my lab is think about how that supports research and interactions. So for example, a lot of the systems that we build, robots, autonomous vehicles, we design them one way and then we test them with people, but we haven't designed them in anticipation of the user's behaviors. So a lot of the testing is then just based on the user acceptance. It's not about designing a better interaction where there's some kind of reciprocal action and reaction from the part of the system. And that makes it very difficult because the first time people really encounter a system is like in the wild. That's not the safest place to find yourself interacting with the technology. So a lot of the work we are doing is setting up multi-party systems where we can look at how drivers interact with one another, drivers and pedestrians, and then incorporate things like virtual autonomous vehicles so that we can understand how those things should be designed. And so, in the in the healthcare and medicine space, I think I'm really interested in situations where the physical environment matters a lot. And also to be thinking about how, for example, around accessibility, how things like delivery robots that are being delivered, set up in our environment, how we can actually anticipate how those things will affect people, older people, younger people, people who have mobility impairments, before we just try it out in the real world.
I think that's kind of neat because I've seen them in hospitals is where I've seen the delivery robots the most. So
yeah,
it's
kind of a surprising thing, they just deploy them.
Yeah, but they're there in this environment. So, and as you say, they're being immediately out there and studied there. So it sounds like what you're talking about is thinking about how to do user studies so you can iterate on designs before they actually exist.
We do studies. I mean, what we try to do is focus a little bit more prospectively on design. So we, for example, will do things where we're more workshopping what the behavior should be like and less like having some set design and then just testing how well it goes.
That kind of moves me to ask about your projects. I think that's also where you're at in terms of the agent interaction. So could you tell us something more about that project and the process of sort of getting knowledge from potential users? So would it be fair to say that the physical environment, in this case, you're looking to let people escape from the physical environment? You're pulling people out of the physical environment to let them experience beautiful virtual?
Because they're with them, when they're stressed, the young kids, they're watching YouTube, not YouTube Shorts these days, or games. So they can take them away from their reality, but as soon as they stop, then they're back to reality. So we try, and since they are already with the phone, then we are trying to put this agent in their palm. And then also headset, so it means metaverse platform, you can actually go cross platform anywhere. So it's available on cell phone, computer screen, headset,
According to the rest of our speakers, yes. So Alex, I know that you're a busy guy. So tell us about your work in this and what you kind of have, but elaborate on the agents and physical environment, and then we really will be able to have questions.
So I've been talking for a while. I'm going to change things up and I'm going to appeal to the computer historians. We've come a long way of Ivan Sutherland's sort of Damocles for the people. But basically what has been happening is this area has been populated with a lot of acronyms that fall under it. So AR, VR, mixed reality, and then we're trying to find a space how this can be useful. And in this reality that now has more tools to work, there are coming autonomous agents. We're talking about, for example, purely on AI, about machine learning. And we're talking also about large language models and the role that they play. So the two examples that I had prepared for this one was the one that I was talking before with Cornell and Qatar. Anecdotally, I was already logged in and I was ready to receive the students. And one of the students tells me, you are a robot, you are AI. And I'm like, I'm definitely not AI. And we're not there yet. It's like, prove it. And I'm like, I'm a professor in New York. The other was a student in Doha. And I said, I most likely could fail you in this class. And they're like, okay, you're not AI. So one of the things that I want to show, and there are two flavors of AI that, for my clinician friends, that we are exploring. One is the idea of
Briefly tell me about problem-based learning.
So the idea is this PBL patient that has large language models and you're conversing with it.
Problem-based learning, PBL, is an instructional method where students...
It goes on and describing a concept, and the idea is as this technology becomes better and the avatars with the help of Andrea and the team become better and more closer to what would be ideal for us to consume, whether it's hyper-realistic or not. And as AI becomes closer to what understands us and doesn't hallucinate every now and then, there are new avenues of how we can converse. And there's this rhetorical or more philosophical kind of question, or where does AI fit in the care? Is it helping clinicians? Is it replacing clinicians? Where does it add value? And as Kurt said before, regulation, reimbursement, otherwise it's plugged. So the idea here is touches about medical education, but to blend a little bit with the reality is, what if this patient could be in your dorm room and you could say, like in PBL, 45-year-old male suffering about back pain problems, go. And in comes to life an avatar that has specific demographics that might push your unconscious bias. And maybe it's like a New Yorker in pain and is not happy to be there and immediately starts, putting the doctor right through hell, what, the clinicians experience on a daily basis. It doesn't wait for a prompt, like the New Yorker patient, right? So the idea of where we see this technology and this autonomous agents is with LLM, there is a lot of discussion on ethics and the role that they can play. But in terms of medical education, provided that we can capture the guardrails and how they operate, there's value to explore. And then comes the last one, which is a seamless plug for Sandhya's poster, where we approach things with the machine learning level, where clinicians have spent copious years validating the data. So one of these projects, just to give you context, and I want to mention all the amazing team that we have, but perhaps Dr. Zaninovic and Rosenwachs, who are the embryologists behind. We at Cornell in New York, we have perhaps the largest IVF clinic in the world. So at any given time, from a big data perspective, I would say what we have pales in comparison to all the other groups that we have, meaning copious amount of work of clinically annotated embryos becoming blastocysts for over like 2 decades. So the work of these two people and all our amazing AI team with Dr. Hazira Suliha, Dr. Elemento, all these people that you see, we went on and created a barrage of papers over the last half decade. We called it STORK. And STORK was a model that can give you 98.8% accuracy, identifying whether an embryo will lead to a potential miscarriage or a successful pregnancy. And it's like, cool, a lot of data, Nature publication, different versions and iterations where, maternal health and age comes into play. And there's another clinical attribute than just the imaging. And now comes the important part with the conversational agents and perhaps the remote part from before. Can you bring 2 embryologists in the same room, regardless what they are? And can you materialize that data in them? So what you see here is the light field microscopy of embryos that they can traverse. This is like a given embryo, the 5 days. It's a 4-dimensional data set that has over 65,000 images. And then we augment kind of with some sort of like Gen AI, kind of trying to fill the gaps in between of what could be in these layers that we haven't imaged yet. And there is the traditional machine learning model that would tell you in a deterministic way what the clinician trained it to do. And then there is the other part, the cognitive load state, where perhaps LLM can help. And it can either be an agent that you could call and say, what do you think about this? And maybe Dr. Rosenwachs is not available today, but maybe Dr. Rosenwachs' avatar can appear, trained and learned and studied all his papers, all his reviews, and kind of fit in the sounding board as I'm debating on something, right? Could it be this? Could it be that? Could it find perhaps a false positive that would make me think and establish and give me a new perspective? And the last thing that I would say in these kind of AI avatars, should the person that says XR20 be a real person? Should it be an agent? Could it be both? And in the future, what we expect, what is the true role of these autonomous kind of the methods where we started talking about, right, in the beginning, that these agents should interact? And think of it, and going to the last sentence in the medical education, let's say there is a modern family that goes to has tried everything, and the IVF becomes the last resort. And think of the embryologist being able to place in the table data that would be almost impossible to communicate, and say we're selecting this embryo because this and that. And there is now this tangibility for someone that didn't do their PhD MD at Cornell, and they don't share what you guys have shared copious amount of effort, and it's like that explainable AI or the tangibility that these technologies can bring into our physical environment. So with that, I would say if you want to try the demo, talk to Sandhya, and I'm done on my end. I think I went a little over.
I think we still have 10 minutes, so I have some questions, but I did say I would open up to the audience, and I see some smiles. So can I walk the microphone around? So we sort of left with a strong pitch for the utility of AI. I was going to ask about risks, but does somebody else have a more specific question? And I saw a hand, but it went down. Over here. Okay, tons of hands.
Hi. You gave an interesting example about like if the professor isn't there, then maybe we can have like this like virtual professor and like load in all the data about like their papers and um, reviews and all that kind of stuff. And I was just wondering where like a potential like ethical line is with stuff like that. Like, is there like, I don't know, a sort of like impersonation happening there or like, I don't know, just what your thoughts are.
So if you're considering the ethics perspective, right? I think this is not an area that has matured and there needs to be more discussion. I can tell you anecdotally, we were having a discussion at NIH in Bethesda, and we were talking about, one of our colleagues was saying, who knows what a drug called the Tangerfruit is? And like, think of a panel like this and 10 people raising their hands, and they're like, cool, who has prescribed the Tangerfruit? There's like 3 people that are raising their hands, like, cool. A Tangerfruit is a made-up drug from ChatGPT. We should talk, you know? Meaning on how AI is being used. I don't think we have the right guidelines. And in the past, we were thinking of the Terminator incident, and we were thinking this is science fiction. Technology has advanced to a point. We're still not in the Terminator stage, but we're at the stage where serious discussions should happen in the ethics. And I don't know if we have the right ethics people in the room. These help you come out with more questions than you entered the room. But I think it is important to explore the areas where there's value. To Kurtz and all the clinicians said, the value behind, do not do harm, how you can really add value, but how you can also offload a lot of the tasks. So maybe the LLM is something that can answer questions at 2 a.m. Maybe it can help do some of the pajama time, right? Why not? So where the ethical balance would be, I think, it's also in our community and society to try to find its right place. It's not something that should be decided in a room with like a couple of experts, right?
Can I ask a question to the crowd, actually? I mean, this is my interest in coming to this workshop. I mean, where we are on the technology front is that the main advances, I think, are happening in VR and the mixed reality technology are happening on the sensing side. Like we have maybe on the visual side, something very similar to what we used to have. But for example, it looks a lot better because the headset's ability to basically localize itself in the room has gotten so much better. So the virtual objects seem to be locked into actual space. And the ability for the headsets to be able to send out like sonic signals and basically get information about where objects are in space, what the materials are, is going up. And it's some of the technology like literally is also being used in robotics and autonomous vehicles being miniaturized to the point that you can wear it on your head, So I think what I think are the really interesting opportunities that we haven't had so far are just the ability to know a lot more about the physical environment, to think about how the technologies we're doing can now interact with the environment in a way where, virtual reality used to be separate from actual reality. And now we can actually do things where we're looking at things that are embedded. So some of the work we're doing is thinking about how people move around in the actual space around virtual obstacles. But one of the nice things is you can also have physical obstacles in the environment. So both the naturalistic and the virtual, you can have them in the same space. And I'm really interested to know in medicine, what are the things that are interesting that this technology makes possible? And it's not going to be the stuff in a classroom. It's not going to be the stuff in a kind of controlled surgical environment, because those are the things that the old technology did really well. But what are the aspects of health and well-being where being able to go out and be in the world with the immersion would be really interesting?
I've got a microphone. Do I have someone who wants to answer that question?
Sure. Well, piggybacking on some of your work with the gait, work with Parkinson's, I think, so in anesthesiology, we interact with patients, the preoperative, intraoperative, postoperative aspect of the cases. And a lot of the work that many anesthesiologists are doing is actually in the preoperative space in terms of preoperative assessment and also this notion of prehabilitation before surgery. So getting people up above, assessing risk for surgery, and then finding out someone who might be frail or optimizing them, bringing them to the operating room at a higher level so that then when they undergo the inflammation of surgery going downhill. One of those areas is the detection of frailty, and there are a lot of different markers for doing that. One of my colleagues, Joe Scarpa, is actually doing that in our department, where he's actually doing a trial where he has people do what's called a 6-minute walk test, and assessing for whether or not they can get up and go around and do all these different things. But I think in terms of like the preoperative assessment phase, there are a lot of opportunities in terms of detection, things like voice, things like being able to get up and walk, being able to look at attention for a certain period of time and be to detect mild cognitive dysfunction before surgery. Like these are a lot of different options that would be useful.
Yeah, that's great and specific. May I give the microphone to someone else?
A question for Alex. You mentioned the term, you mentioned embryology. I was wondering, do you have any models for teaching the development of the heart and the gut? Because I got a lecture coming up and I'm a little tired of using the YouTube videos.
So you said if we have any educational videos for the heart, did I get the
heart and the gut? Is that what I heard? Yeah. So, do you?
I mean, the short answer is no, but
Okay.
we could work together to develop stuff, or maybe people in the group might be interested to collaborate, or maybe someone else has.
So this is a great lead-in to the conversations that are going to take place in just a minute. I had one more question, I think, and then we'll be at 5.
I guess I'm wondering about bringing the patient into the clinic also, and whether some of the technologies we're talking about would be helpful for that. So connecting to the autonomous agent, it makes me wonder about the simulation of the doctor that we've been talking about, potentially offering options. Would the simulation of the patient in real time also be helpful? So for example, if you gave a dense, 5-minute video footage of yourself to your doctor, and then they're asking questions of that sort of data space that you've provided them. Like we've been talking about autonomous agents as the service provider side, but is there any reason to imagine the service receiver's simulation being helpful? I don't know if that makes sense.
I would say, James, it helps promote patient-clinician interactions, right, from the get-go. I think a lot of clinicians have unconscious bias that they don't know because they haven't been culturally exposed in areas that are different than their upbringing. I'll give you an example. So Weill Cornell in New York and Weill Cornell in Qatar essentially get the same degree. You become a doctor and it's synonymous. You can practice medicine in the US. They have exactly the same exams. Culturally, and maybe that's a New York thing, we maintain eye contact. And this is how you convey that you're paying attention to my answer, right? In Doha, if I am your clinician and I'm staring at you, this is not what is the cultural norm, right? And I'm just giving you a simple example of how getting that training and how VR could help you. There's eye tracking, there are specific things that you are saying. Could I have markers? Think of like baseball or NFL, or there's so much augmented reality where the goalpost is, right? Could there be some sort of replay that I as a clinician can go and see what was my unconscious bias, or what were ways that I could have been a more effective communicator? And that, for example, who doesn't know as a clinician what bedside manners are? They're so integral to our core. And when we went to Zoom, how did these bedside manners translated? a lot of our colleagues in the emergency medicine that were doing a lot of telemedicine were saying that if I drop, for example, my pen down as I'm fumbling in my Zoom setup, you know, at the start of COVID, and I disappear from frame, or if I'm struggling with tech, because by the way, I'm a doctor, not, you know, IT, what would the patient think of me? And how can I, you know, have this technology prepare me? So, you know, you could do so many simulations, to your point, with all these potential scenarios of patients that you never get. So for example, in New York, gunshot victims are most likely going to appear in Times Square. Geriatrics in the Upper East Side, I think we're very strong at that, like demographic population. So there's a lot of opportunity and potential to develop like a ton of different applications that the patient should be front and center.
If I could jump in, like one thing that I'm really interested in is like local culture and norms. And like, I thought it was really interesting. I think it was Andre that was saying that like virtual places are also places they have their own cultures and norms. In the space that I work in, like in robotics and autonomous vehicles, very often the technologies are being developed in very specific locales with very specific cultures. For example, for driving. And like Waymo, for example, is like accumulating millions of hours of understanding of driving, but of a very local San Francisco driving culture. And anyone who's ever rented a car and then driven someplace, you know, not in their home city, knows that even if you know how to operate the car, driving is a very different thing everywhere you go. One of the things that I think is really cool about VR technology is we can actually be getting a profile of how the interactions are different. And maybe it goes to what you're saying, but like, I always feel very hesitant about a lot of these training scenarios because I don't even know that we have the data to, you know, to be teaching anyone else what it goes. But on the other hand, the VR technology is a wonderful tool for collecting data all over the place that right now we mostly get just in a few places in the world. And then we design these things, we design technology around a few places in the world, and then we deploy them everywhere and foist them on everyone else. For technologies where there are behaviors, it's actually pretty important in my mind that we try to use the same technologies to be sampling behaviors and norms, things like gaze patterns and body movement, gestures, and to think about how we then want to design the technology around what we can learn.
I'm going to ask, so I know we're supposed to close, but you had an anecdote that you told me like years ago about people's nonverbal behavior reacting to cars.
Oh.
I don't want to put you on the spot, but in terms of like people's gestures, like if you waved someone past pass the car, do you remember what I'm talking about?
Yeah. So one of the things that I'm known for is this protocol, which is known as Ghost Driver. And in Ghost Driver, you simulate an autonomous car by having a person in a car seat costume, you know, driving in the car, and then you can see how people in different places interact with autonomous cars. And one thing that's really interesting is that the gestures mean very different things in different places. And so just as a, for example, they were saying that the person I was like interviewing afterwards was saying like, you know, like the people in California are so rude, you know, in the way that they gesture. And I was like, what do they do that's so rude? And they're like, oh, when they want you to go, they go like this, you know, like you can cross. And I was like, oh, what would you do? You know, and they were like, you open your palm, you go like this, you invite them across. I can tell you, if you did this in New York City, you were like this, you would get shot because being so overly polite as to be super rude. And it's just like, it just speaks to how normatively these things mean very different things in different places, and how you can naively, without meaning to, really offend people in the way that you design a behavior.
Thank you. And that brings it back to nonverbal behavior, which I love. So for me, I'm happy to end on that note, not to end because we do have the reception starting at 5:30, but we have a little pause. So I'm going to first ask that we thank our wonderful panel. So I know I rushed you this morning, so this is a great time to check in if you want to check in. If you're a speaker and you want to sign that release form, if we didn't get you already, that would be great. If you can go back to the hotel and come back here if you want to go check on your bags, but we'll have food and drinks here at 5:30 and posters and demo presentations. And so we'll hope to see everybody back here then. But thank you very much for a wonderful evening so far.
So, but it was a very, I that I feel like I never thought about but I mean, what you said about it, like even the first connect that is here 1,000 times cheaper, and now
Hello?
miniatures to a point.
Can I just get your attention for 1 second, everyone? Sorry, I know we just like made everyone go away for a bit, but just want to give a quick announcement about checkout for all of those who are staying in the Statler tonight. We just ask that you check out and like bring all your stuff down. I know it's so early, but check out tomorrow morning before you come because there's not really time to check out after, specifically for those who are taking the bus back. We have to start boarding the bus tomorrow at 5 o'clock. If not a little bit earlier, and they will leave promptly at 5:15. They made sure to tell me that. So again, for those who are staying at the Statler, please check out of your hotel room prior to coming here tomorrow. I will also send an email just in case many people don't hear this, but yes, thank you.
And okay, and actually, I was going to do this tomorrow, but in case anybody is leaving, this symposium was organized by Isabella McLeod-Daphnis, who was unfortunately can't be here today because she had a family emergency, but she did a great job up until last week. And then I also want to call out our wonderful volunteers, in particular, Julia, Kevin, Ria, Reese in New York City. I hope I'm not, Jonathan, all the volunteers wearing their swag around. Thank you so much for stepping up and making this possible. That's it.